Dear participants of the 11th City Health International Conference, my name is Tanshtiq Astabes. I am a PhD student at Bishkek State University. I am currently researching the specifics of social work with drug users in the probation system of Kyrgyzstan. Kyrgyzstan is a Central Asian country with a population of more than 6 million people. In this presentation, I want to talk about the probation system of Kyrgyzstan, its achievements and problems. The probation system in Kyrgyzstan is at the stage of formation. The process of establishing the probation system took almost 2 decades. The probation system was first mentioned in the scientific community of Kyrgyzstan in the early 2000s. Following this, the government began gradual work on establishment of a new socially oriented institute. The law on probation was adopted in 2017, which came into force 2 years later in 2019. In the same year, the probation department was established under the Ministry of Justice of Kyrgyzstan. According to the law, the probation system consists of government bodies, NGOs, and the public. The main one in the system is the Probation Institute, which regulates the activities of the probation system. Government bodies are actively involved in the system. For example, when the probation clients need medical care, the Ministry of Health assists in this. It is important to cooperate with local self-government bodies when the probation clients need to replace lost or stolen passports. NGOs and international organizations, first of all, help in the development of regulatory documents, training of employees, social workers, and psychologists. An important role, of course, is played by volunteers who contribute to the development of the probation system in Kyrgyzstan. Despite the short period of existence and the COVID-19 pandemic, the probation system has done a lot of work and demonstrated great achievements. Currently, local representative offices of probation are functioning in all regions and big cities of the country. Probation clients contact local representative offices at their place of residence and receive necessary psychological, medical, legal, and other assistance. As of September 30, 2021, the total number of probation clients was more than 14,000. For 9 months of 2021, thanks to the activities of the probation system, 179 clients were employed, 193 clients had their personal documents replaced, and 117 clients were trained. The probation system has had a positive impact on the country's prison system, which is in a crisis situation now. The functioning of the probation system has led to a reduction in the prison population of the country. In 2020, the number of prisoners decreased by 11% compared to 2019 and by 21% compared to 2018. The main problems of the probation system are associated with low salary and lack of human resources. Many specialists leave probation due to low salary and get a job in international organizations or NGOs where salary and working conditions are much better. Also, there are no universities in the country that produce psychologists and social workers for working with probation clients. Many young specialists and students do not want to be volunteers. For example, as of November 2021, only 18 volunteers are registered in probation. Given the advantages of probation over the prison system, it is hoped that the government will pay more attention, as well as international organizations and NGOs will help in building an effective institution, the probation system in Kyrgyzstan. Thank you for your attention. Join us for the 11th City Health Conference, the 29th to 30th of November, live in Warsaw and online.
Starting off this first session of the second day, I think this is going to be a particularly interesting session because really it's taking stock. So it's looking back a little bit at perhaps some of the things that we've learned or relearnt in the last year or so, but also looking forward to some of the challenges that we know we're going to face. The focus is, there's going to be a focus on prisons and the criminal justice system, but also a look at some of the broader issues that services face. The format for this morning is basically we have 5 excellent presenters who are going to try their best to keep to 5 minutes to present some key ideas. I've just been given the thumbs up by one of the presenters, which I'll take as an assurance it won't be any longer than 10 minutes. And then we're going to have a discussion which we hope the audience can join in as well, when we explore some of the issues more deeply. Now, the first presenter we're going to have this morning is Margina Excel, who many of you would have seen last night receiving her award. Margina is a surgeon who qualified in medicine in Krakow with postgraduate training in healthcare management. She's worked in the University Surgical Clinic in Krakow, as well as in a mission hospital in Zimbabwe and the surgical ward of the prison hospital in Krakow. She progressed to become head of the prison healthcare service in Poland from 2000 to 2008, and subsequently for 12 years up until 2019, was a member of the Committee for the Prevention of Torture of the Council of Europe. Now, Dr. Excel worked part-time as an independent court doctor at the Regional Court in Krakow and remains a Council of Europe expert in the field of healthcare provision in prisons. So, Margina, the floor is yours.
Good morning. Thank you very much, David. And I will speak Polish. Postanowiłam Państwu opowiedzieć o takim koncepcie, który Światowa Organizacja Zdrowia i inne organizacje
World Health Organization and other organizations, and this concept has been propagated by such organizations. It's a concept where people who are placed in various institutions, which you can call a healthy prison. Well, this is a healthy prisons concept. Why is that so important? It is important because they should leave those institutions healthy, physically and mentally. It's very important to have the right, secure environment. They should serve the sentence, to serve the penalty in a secure environment. In the environment that there are no torture, there is no mistreatment. When there is no violence among prisoners, when there is ensured ongoing access with the external world, it should be a place which should provide adequate material conditions, such as a proper space for each convict, and not an overcrowded place, definitely, and each convict should have his or her own bed, access to natural air, natural light, potable water, and frequent shower or possibility to use a bathroom, access to high-quality food, or so a person who is serving his sentence should be provided with access with certain activities that would not undermine him, but that would develop him, like studying, properly paid job, cultural activities, sports activities, and adequate healthcare. A healthcare that should be custom-tailored in such a way and adapted to the needs of such prisoners. Such healthcare that is free of charge, healthcare that is the same as the one and equivalent to the one that is out of prison, that is offered to the other part of the society. So if we are talking about adequate healthcare and adequate conditions, well, it's not only about the access to doctors and nurses, and there should be adequate access to medications and access to modern diagnostic tools, specialist treatment, but also the medical staff should be independent because it's of core importance. And now shortly, let me tell you briefly what has been done or what is being done all over Europe to achieve that concept of a healthy prison, a concept that is, look at the picture of it there, it's one of the prisons in Norway, so this is our objective. So there are many different activities which are happening all across Europe. And I believe that it's a huge achievement, that there are many European or international institutions which started talking about prisons and providing health service in prisons. So these core actors on that scene could be the European Union and the Council of Europe and the World Health Organization. And over the past few years, new prison rules have been adopted, and they were named after Mandela. These were the minimum rules, and they state clearly that the access to healthcare should be provided free of charge. And there are many projects that are implemented all over, like Georgia, Montenegro, Armenia, and they are implemented by the Council of Europe, and they are funded by the European Union. And the European Agency for Prevention of Drug Addiction has recently released, I think I'll be able to tell you about that more. Our Highness Tover will tell us about that. They released a document on prisons and drugs and current challenges in that respect. So, the European Centre for Prevention of Transmissible Diseases are releasing their regular recommendations and guidelines on what should be done in order to prevent contagious diseases in prisons. So the program launched by the World Health Organization, the Prison Health, is also quite popular, and there are some documents released on what should be done, on what has been done, and a paper has been presented in that paper. There are 38 different countries present their stats concerning healthcare in prisons. And there's a last thing that needs to be stated. The last challenge that we had to face was the COVID pandemics, and I believe that everybody who has something to do with prison systems knows that in a closed, confined places, fighting COVID is a huge challenge to cope with. So starting from the very beginning, there were lots of protocols, there were lots of guidelines and rules on how we should prevent spreading of the COVID pandemics. So if you would like to find out more, I'll just come back to that topic during our discussion. And there is, of course, much to be done. And in many European countries, the policymakers are still not interested in investing into healthcare in prisons. So I believe that the main reason is that we don't have a hard law. So all our recommendations that are developed by specific committees, that they are just soft laws, they are just guidelines. There is nothing in legislation, a national legislation, that would obligate the governments to introduce such laws. There are lots of problems with stats, with collecting data, and I believe that there is that we don't have a coordinating institution in place, an institution that will coordinate action undertaken by older institutions, such as, for instance, World Health Organization. They're doing quite a lot, and because they're, well, however, all these organizations are competing with each other instead of coordinating the cooperation. So thank you very much. I think that I've run out of my time.
Thank you very much, Marzena. We're going to stay with prisons and the criminal justice system with the next presenter. We're also going back to Scotland, which may be a challenge for the translators, but we'll see. So I'm very pleased to introduce Michael Stoney, the head governor of Her Majesty's Prison Barlinnie, the largest prison in Scotland, operated by the Scottish Prison Service. It is located to the northeast of Glasgow and houses over 1,000 men.
Good morning, everyone. What I would like to do this morning is give you a snapshot of the position we were in prior just to the pandemic hitting and how we've accelerated out of that, bearing in mind the pandemic's still alive. So I'm going to give you a bit of background. We have a situation called the Glasgow effect. A study was done by the Centre for Population Health in 2010. That evidenced that Glasgow had a real problem with early mortality. The comparison study with Manchester and Liverpool evidenced that we were experiencing 30% more deaths than the other cities, despite the same economic profile and the same post-industrialisation. This was a real concern, and we were looking at where we would be in terms of the position and the reasons for this. It's been very difficult to identify. The study more or less concluded at the point when it reviewed in 2016 that Glasgow has suffered extreme vulnerabilities in terms of the policies and processes being applied to the people of Glasgow. And there was this so-called democratic deficit, which evidenced feelings of disempowerment and lack of control, and that was impacting on people's health, and these psychosocial risk factors were prevalent. Taking it up to the latest data, there is a real emergency in Scotland just now with drug deaths, and the figures for 2021 were the highest ever recorded, 1,339. Glasgow City alone had 291 deaths in the year 2020. There are real challenges as well. We have got a lot of people who are suffering from adverse childhood events and the trauma associated with that. And we see that every day in prisons. A lot of my population is a very vulnerable population. So we've tried to take a health-focused approach as opposed to a criminal justice approach, move away from as much as we can on offending behaviour programmes and move towards a health focus. The prison, as we know, impacts on mental well-being, and there are real concerns over feelings of safety for the men in prison. The drugs that we are experiencing now, a real issue in terms of the psychotic substances, spice, and also very, very strong benzodiazepines such as atizolam. There's a real risk-taking behaviour in prisons as well. We see people overdosing the staff to provide naloxone, and the same day when they come back from hospital that night, they overdose again. So there's not really a concern in them about the risks they're taking, and we're trying as much as possible to educate people. The positivity of COVID when it hit, it's a strange thing to say, but the positivity was people felt safer. And what it also did, it humanised the prison because the staff were also experiencing the same circumstances as the men in prison. Everybody felt as if they were in prison during lockdown and there was not a lot of opportunity to do anything. So it tended to humanise, and the staff and the prisoners had a commonality and a common approach. When stopping all activity in the prison, what we found was the opportunity to change things came around. Prisons are very traditional and it's very difficult to change what you do. But because something unique, like a pandemic happened, we were able to stop what we were doing and move away from that towards this health-focused approach. So what we wanted to do was build resources in people, figure out what they really needed in order to function in the community and to survive and thrive in the community. We took the approach of salutogenesis, which is a phrase coined by Aaron Antonovsky, a sociologist, and he was particularly concerned with the relationship between health, stress and coping, and that's the experiences we see in prison with the men every day. What we want to do in terms of his the sense of coherence is a position he felt that if you have a strong sense of coherence, you have more chance of thriving or surviving. And there was three main areas of, one was comprehensibility, manageability and meaningfulness. And what we've tried to design in the prison is approaches that will help build up people's sense of where they are in the world and their understanding of their position, understanding they may have suffered trauma, but trauma can be healed and they can move on. Also to give them the skills to be able to manage their own life, focus on real skills development that will help them function in the community as well, and then also find a bit of purpose. People struggle when they go back to the community if they're trying to change their lives because they actually don't know what to do. They spent a life chasing drugs, alcohol. It was a very busy life for them. If they try to stop that, they've got to replace it with something, and we need to focus on finding a sense of purpose for the individuals. So we designed our own a priest of inquiry model, which is a very co-productive process which allows individuals to identify their own resources within themselves and allows the staff to co-produce a plan with them. This focuses on building self-esteem and agency. It provides opportunity for skills development, but the skills that the individuals want and not ones we tend to try and enforce on them. And also look to provide a utility for these skills, find them an exit out into the community to use them. And also, we really need to identify the options that people feel are purposeful, not just the ones we impose on them. The other important aspect was this, providing a vibrant, safe community that we allowed people access without concern. Prisons are a very difficult and dangerous place at times, and people don't feel safe, and therefore it prevents them from accessing activity and things to do. What we created was an area which was very approachable. It was a recreation area, it had a library, had education facilities, but also the staff, their approach and attitude was very positive and engaging, and we used a lot of peer-led initiatives as well. What we got was people attending that area just to spend time with their friends, but actually starting to engage with agencies that would help them through housing, employability, or just emotional psychosocial supports. And I hope to stick to the 5 minutes, Dave. Well, thank you.
Thank you very much. We're going to move on temporarily at least, away from prisons a little bit, but we are sticking with the Scottish theme. And I should perhaps point out for some people that it is actually St Andrew's Day today, so Scotland's national saint. So it's only right and proper that I get to introduce another Scotsman for his presentation, Martin Corley, who has been involved in health and social care throughout his career. He's previously held senior positions in a number of Scotland's charities and spent 3 years as director of the National Lottery Community Fund in Scotland, working with charities and community organisations. Since 2019, he's been working as CEO at the Beatson Cancer Charity.
Good morning, folks. I will try and stick with 5 minutes just to keep everyone's attention, but it's very difficult to get all of the points that you want to make within such a short space of time, but nonetheless, we will give it a go. I'm coming from the point of view, not necessarily of a prison environment, but more of a lifestyle, community, inclusion sort of perspective. I'm going to touch on 3 themes. One is citizenship, the other one is collaboration, and the other is leadership. And I would contest that these 3 components, themes, are the key ingredients to deliver successful, meaningful, person-centred services for people with a variety of issues and needs. There's a guy called Michael Rowe, a psychologist from Yale University, researched a lot of work on the theme of citizenship. And he argues that there are 5 components of citizenship. One component is based on rights, the individual rights that one is afforded by the society or the state. One is the responsibilities that one has to acknowledge, absorb and portray and to be an active citizen. The other is relationships with other people, other citizens. The other is resources. And the other one is the roles that people play, the 5 R's of citizenship. Now, when you think about that, if you exercise your rights as a citizen and don't exercise accept the responsibilities of a citizen that many people who find themselves in prisons do because they compromise other people's rights, then you won't be able to participate as a full and active citizen. So each of these 5 components is very much interrelated and important to each other. So in my view, to deliver successful progressive services for people, organisations seriously need to think about how they encourage, support, promote and engage people to think about how they engage as active citizens, because each of these components is so important and interrelated. I don't think that's possible as a sole agency. I think you can only do that in collaboration with other people, other organisations. And I think the state plays a role in that, of course it does, but it's not the sole role. And in my view, the most successful services, and we heard a few yesterday, and when you think about that in a post-COVID world, the most successful services and the ones that will deliver and people's needs most will be the ones that act in collaboration and partnership with other agencies. You cannot do it alone. So the notion of collaboration is something that is very, very important in relation to deliver successful services. That often can be compromised because of the way services are structured, delivered and funded. And that's quite a shame, because if they're funded and delivered in competitive processes, competitive ways, then it can compromise the motivation for collaboration with other agencies. And I think that's something that agencies need to think about very carefully. And that, for me, brings me to the last point, and that is the importance of leadership. Without successful, participatory and transformational leadership, then you don't have all the ingredients that you need to make the difference that is so important to have the biggest and most positive impact for people. And leadership comes from many different ways. It comes from people themselves, and some of the most successful services and best services you will see and you will find will come from citizens themselves who step up to the plate and act as leaders in society, and organisations need to follow suit. Organisations are only one component part of that, and if they don't treat people with respect, dignity and citizenship, then they will miss a trick, they will miss the point. The last point I would like to make, and I would urge you to try and read some of this women's work, is on the theme of dignity. And I was reminded of this yesterday during your talk. A woman called Donna Hicks, who her background again is psychology, but her career progressed through conflict resolution. She worked in the Middle East, she worked in Northern Ireland. She's an American psychologist, but she's worked across the world supporting governments and organisations and agencies in the field to think about how they can resolve conflict. And Donna argues that you won't resolve anything unless you recognise dignity and the dignity that is afforded through people. And she suggests that dignity is an intrinsic human right, but also an intrinsic human need. And the more you offer dignity to one individual, the more you boost their dignity and reinforce your own dignity at the same time. So Donna suggests that unless you actually focus in a concentrated and deliberate way in affording people dignity, then you won't achieve anything. So if you can think about that in relation to conflict, you can apply that in relation to health, public health, citizenship, inclusion, self-determination, and all of the fields and areas that we think about on a daily basis. So I would leave you with one thought, and that is, how can we afford dignity to one another in an environment where sometimes the pressures oppose dignity itself? Thank you very much.
Thank you very much, Martin. Some very big ideas there, but some very important points, I think, made as well. Next up, I'd like to invite up Heino Stover, who I know is known to many here. Main fields of research, project development are health promotion for vulnerable and marginalised groups, drug services, prison healthcare, and related health issues, especially HIV, AIDS, hepatitis C, drug dependence and gender issues, and also around the potential of e-cigarettes. His international research and consultancy expertise includes working as a consultant for the European Commission, the United Nations Office on Drugs and Crime, the World Health Organization, the European Monitoring Centre for Drugs and Drug Addiction, and the International Committee of the Red Cross, as well as the Open Society Institute in various contexts. Heino.
Thank you very much, David, for this introduction. Welcome, everybody. I will talk about an issue which accompanied me throughout my career, and it is a typical city topic. We'll talk about drug consumption rooms. Earlier, in the late 80s, early 90s, there was a very interesting city network around Europe, and it hosted many cities who were tackling the drug issue in their communities, in their municipalities. And this is because all of them do have similar problems in tackling drug use. And out of that came, I think 1990 something, yeah, I said it here, the so-called Frankfurt Resolution. I only put a few sentences in the beginning. We, the signatories of the Frankfurt Resolution have agreed, sorry, I have to read it here, to continuous exchange of experience and cooperation with respect to drug policy, and the attempt to eliminate both the supply and the consumption of drugs in our society has failed. The demand of drugs persists to this day, despite all educational efforts, and all the signs indicate that, thanks a lot, indicate that we shall have to continue to live with the existence of drugs and drug users in the future. Very important sentences of this resolution. Disappointingly, the network does no longer exist. I don't know the reason why, but it was, let's say, a network with people who all, or with municipalities who all had the same problems. And one of the problems is the drug-related mortality. We heard a lot about Glasgow already, and I will continue a little bit with the experiences we made in Frankfurt in Germany. So first of all, the EMCDDA, the European Monitoring Center for Drugs and Drug Addiction, Lisbon, did recommend the following steps to reduce fatal outcome of overdose: supervised drug consumption rooms, take-home naloxone that has already been mentioned, and then, of course, opioid substitution treatment and many other things. And this is the key strategy we should follow. And we did it partly in the implementation of drug consumption rooms. DCRs are part of a broader harm reduction strategy, you all know, are part of a city-based security strategy as well at the same time. And it is an integral part of public health. And it serves both health and security interests. So it's a win-win situation, I would call the success for implementing 25 of these rooms in big cities in Germany. Win-win, the police, the public security is winning, and the health of the people is winning as well. And that might be the explanation of the implementation of these 25 rooms. So still, DCRs are a symbol of the fact that neither drug services nor police alone can bring about change to the drug problem. You see here, we've got 4 of these rooms in Frankfurt near the main station. They're not looking very cozy. You should not stay there for a long time, half an hour maximum, and then you have to get out. We do count, our institute is monitoring these 4 consumption rooms. We do count approximately 200,000 consumption events, injecting, inhaling, whatever is needed. Between 4,400 and 5,000 clients annually, decreased in times of COVID-19 substantially. Aging drug users with multiple health and social problems, and women are completely underrepresented, a topic I will come back to that. The new government of Frankfurt now issued a women-specific drug consumption room from women, managed by women, for women. And finally, we have now 24/7 opening hours. We've got, and this might be the most convincing part of the whole story, we do count approximately 1 emergency case every day the whole year, either within the drug consumption rooms or in the neighborhood around these DCRs. Lots of them we call the emergency, we call the ambulance, and we do count, have a lot of hospital admissions, but not a single case of mortality, which is very important as an argument in the debate. So we do have security partnerships, which is needed between police and social work, health work. It's a continuous exchange of views and activities on 2 levels. First of all, we do have the meta level of drug administration, drug services, AIDS support services, police and public prosecutor. And on a second level, the level in which we are working, where really work is being done, it's the operation level, drug services, AIDS service, and police only. So we do exchange views on how to manage it best, how to tackle the problem, and then we go ahead with that. Yeah, we see that this is a lifelong process. Communication, coordination, and cooperation, I continue with what you just said, is the key of, let's say, running these services in a proper and decent way. Transparency is needed. It's a consensual basis to balance different interests of health and security. And we do have benefits in low mortality rate. You see here a graph which is showing you the height, the peak of drug-related deaths in 1990, 1991, 147, and then the DCRs have been implemented, and methadone program has been started, the heroin program has been started. So regarding to 5,000 drug users within Frankfurt, at least 5,000 injectors, it's quite a stable rate of between 20 and 30, sometimes 35 people who die prematurely because of opioids. So the conclusions: DCRs reduce mortality substantially. They have a bridging function into detox and therapeutic and housing services, whatever it is needed on a social way. But DCRs are only present in 8 of the 16 states in Germany, the 16 Länder. That is because we did not convince the other 8 to implement these drug consumption rooms. You can imagine the rejections of these Länder. That is a ticket to, let's say, tolerate drug use and many other issues. And finally, we only have it in the big cities, Hamburg, Frankfurt, Berlin, but not in other cities like Munich, where we have a high rate of premature death, just because the Prime Minister of Bavaria is not in favor of these contact houses. Many thanks for your attention, and we will talk about prison within this round. Thank you very much.
Thank you very much, Heino, and important reminder there. I mean, I wish London and England had the level of stable drug-related deaths that you were just telling us about, because Scotland has the worst in Europe, but the whole UK has not done very well on drug-related deaths at all in recent years. I'm now delighted to invite up our final presenter, Magdalena Domkowska, who is an advocate and strategy expert working with civil society groups and organisations, both locally, nationally and internationally, and has been doing so for the last 13 years. She's worked in the fields of public health, drug policy and human rights, and has worked with institutions such as the Global Drug Policy Programme of the Open Society Foundations, AFU, Helsinki Foundation for Human Rights in Poland, among others. Currently, she is implementing the EAAD BEST project, which aims to reduce the burden associated with depression and suicidal behaviour at individual and societal levels here in Poland.
Good morning, City Health. Thank you very much for the invitation, for the warm welcome. Before I start, let me just make a note that, of course, the cooperation and work with numerous institutions over the last 14 years, and Dave mentioned a few of them, informed my thinking and shaped my opinions, but I would like to stress that I'll be sharing my own today. I do not perceive saying anything particularly controversial, but I'll be speaking from the perspective of the civil society, and I'll be talking about human rights, so who knows. I'll be talking about human rights because this is the field that I come from. And since the very beginning of my engagement in drug policy, which was almost 14 years ago, I've perceived drug policy as a human rights issue. Therefore, thinking about past years and trying to imagine the ones to come, I would really like to draw our attention today to the shrinking space for civil society, the phenomenon that can be observed around the world, including in Europe, including in the Western countries. And of course, shrinking space for civil society affects the work and the existence of many different actors, including free media, academia, including NGOs active in different themes. But I would argue that when we think about subjects that are unfortunately controversial, that are misunderstood often by the society, that are complex and complicated, I would argue that then this phenomenon is doubly disturbing. When we think about drug policy or harm reduction, then civil society as an actor plays the key and leading role. And when we imagine what civil society does, and then we need to admit that civil society is the main, if not the only actor often, that delivers harm reduction services, that advocates for bold reforms in terms of drug policy, that shares the knowledge that is non-biased, that is evidence-based. Therefore, these roles cannot be really diminished. But then when we think about what burdens, additional burdens, shrinking space for civil society can put on these institutions and organizations, their existence, everyday existence, is challenging enough. So if we put the additional burden, which could be additional difficulties to obtain state funds, that could be censorship, that could be misinformation on smear campaigns, attacks in the media, then we'll figure out that actually the existence of this field may be really threatened. And we could see that at the time of the COVID pandemic. We could have a taste of what it means when we need to operate when our freedoms are really limited, maybe for a good cause. But we could see that, how it is to deliver services when these freedoms are limited. So on one hand, we all could taste that. On the other hand, we could see that actually civil society actors, community actors, peers were often the first ones to go out on the streets. They were the first ones to provide responses, to reshape their services, to adjust to the needs of the communities, their clients, their peers. That showed us how important this role is. And a lot of good examples of what happened during COVID actually have been the things that civil society have been advocated for so long. These are the conceptions, ideas that we've argued for so long. They are needed, they are a must, and they can be done, right? When we think about OST, finally, bigger take-home doses where possible. Finally, people could get methadone more easily. So, and it's not only about delivering the services. I would say that we could see some positive examples at the policy level. What do I mean by that? We've heard a lot about prisons, and I bet we will do during the course of this session. During the COVID pandemic, a number of countries considered decongesting prisons, considered or even implemented decarceration. A number of prisoners were released out of the prisons. Sadly, in one-fourth of these countries, offenders who committed drug-related crimes were excluded from that motion. But even if we could observe a number of people who committed non-violent crimes and who probably shouldn't be there in the first place, we could observe them leaving the prisons. Has anything awful happened? Did the sky fall down? It didn't. What we observed also, like in my home country, in Poland, were kind of a deprioritization of drug-related crimes by the police. Not to say that was the decision of the police, but basically because we had lockdown, because people could not go out to the streets, we had a ridiculous law by a moment when we could not enter parks or forests even. So the police officers actually were given additional tasks and needed to focus on them. For that reasons, they focus a bit less on drug users. So when I asked lawyers in Poland from the Polish Drug Policy Network who provide legal advice to those stopped with drugs, stopped by the police, did they observe any change during this period? The change was significant. Actually, almost no one was coming to them for the advice because people were not stopped and searched. Did anything awful happen to our society? It didn't. So I think the lessons learned, and I promise I'm finishing here, is that we can see decarceration. We do need and we can implement decriminalization. That will help also on the municipal level. It is doable. We right now know it's doable. Nothing major, awful, tragic happens to our societies then. So I'll stop here and come back to this incredible important role of the civil society in the course of the conversation when we'll be thinking how to implement these good lessons learned and how to sustain, how to survive, even if circumstances are somewhat difficult around. Thank you.
Thank you very much. I'm going to sit down here and we'll have an opportunity for discussion. People can fire in questions. If anyone in the room wants to raise a question, raise your hand, try to catch my eye, and the microphone is there. I think I might start where you kind of ended, Aglet. I'm really interested, and it links to yesterday, really. You know, some of those good learning points, you know, from prisons, wider society that we've been forced to learn over the last sort of 18 months. How do we try to make sure that we don't forget those lessons? Because some of them, for me, some of the harm reduction lessons are things that we knew better. I'm talking in an English UK context. Perhaps we knew better 20 years ago than we seem to know now in 2021, but we've had the opportunity to relearn some of these things. But there's a whole wealth there of things that you were touching on. The sky didn't fall in a situation where often politicians and the media would have gone, this is terrible, and it kind of just happened because it was in the pandemic. How do we capture some of those lessons? How do we preserve that and push it forward? An easy question to start with. But I think everyone can probably trip. If I could start with you, because that was your...
Thank you for that question, and it's a key one, actually. So I would say this is, of course, difficult, but I think that there are lessons learned and tasks for ourselves. And one of my postulates would be just we need to go out of our usual drug policy harm reduction bubble. And it's not only about educating the public. We've been doing that, trying to do that instantly. But taking into consideration that shrinking space for civil society that I actually envision will have and need to deal with that problem more and more. So I think we need to cooperate much more with different movements and to understand we ourselves are part of the human rights movement, for example, women's rights movement. But we also need to translate that into these other movements so they also perceive, okay, this is our field, this is our issue, this is where we need to get engaged. And this is both for the educational advocacy level, for the financial level. Of course, it is difficult to obtain funding for what many of us do, and it won't get easier. So again, to have access to the funds for completely different fields, I think we do need to have that close cooperation. And last but not least, I was talking about how incredibly wonderful and somewhat empowering it was to see that communities themselves that are perceived as vulnerable, how quickly they delivered, how quickly they were on the streets, how quickly they worked with each other. So I would say, let's not forget about them. I mean, nothing about us without us. We can see that in AHV field, that it's somewhat inappropriate to have conversations about AHV and not having someone representing the community on the stage. We are furious here in Poland when we see conversations about women's rights, and unfortunately quite often women are not sitting in the panels. But the same needs to happen when we talk about communities of sex workers, of people who use drugs, of people who experience homelessness. We need to have them included in this conversation with very equal voice to ours.
Yeah, thank you very much. What can we learn? First of all, I think it needs to be identified, the lessons that we have learned within the past 18 months. And there's a lot to learn. So I observed the prison system, which surprisingly reacted completely flexible to COVID. They didn't imprison people. There's a release of prisoners for convicted for non-violent crime. So by 15% throughout the whole issue, money fine or not paid money fine have not gone to prison, have not pushed to prison. So surprisingly flexible. Within 18 months, something came true what we never thought of, that it could be done so quickly. That's for the prison system. That was very surprising. And also in the community, we see that for drug user, also where we fought a long time for was to give take-home methadone for 30 days, and this is now happening. And just to reduce the movements of people who normally should show up in the medical clinic every day and have a supervised intake of methadone or buprenorphine. So this all happens without skyfall. That's a good word. Thanks for that. And we have to carefully identify all those lessons that we have learned and ask and demand for prolongation and continuation of what has been achieved within these last 18 months. And we did so with regards to changes in the regulations of the opium law in order to, let's say, prolong the time of take-home methadone. And also in prison, we are heavily working on the reduction of non-violent crime sentences and release them and use alternatives methods of sanctioning. So this is quite surprising and astonishing, and we build on that.
Do you want to keep going? Yeah.
I think this one's all of the panel.
Yeah. I think I very much support the comments that were made at the beginning. I think civil society is responsive, it's very reactive, it's fast, it moves, it's quick, it's flexible, you know, it's all of those things. And I think often government or state or a system-orientated service delivery is slow, is obstructive, doesn't like change, is resistant. And I think those two things can clash. And I think COVID has shown us that where you allow for some more of that flexible, responsive, reactive approach, then you can make change happen much more quickly. I think some of the work that happens in prisons, in your prison, for example, I think the point I was making about leadership, I think people make change happen, not systems or policies, really. I think policies provide an infrastructure or a support or a mechanism, but it's people that actually make the difference. And I think truly responsive services are those that are driven and shaped by people themselves. There was a saying that popped into my head that was, if you tell me something, I am likely to forget it. If you show me something, I might remember it, but if you involve me in something, I will understand it. And when you understand it, you're more likely to respond to the part that you can play in it. So I think that's really important.
There was actually a question that I'll add on to it specifically for you, and seeing as you've got the microphone.
Okay.
For Manika, about the specific bit, how do we hang on to the learning and the new ways of working? And you did touch on the collaboration.
Yeah. I think I love storytelling. I think sharing stories and sharing information and sharing success. I think some of the responsive services we heard about yesterday, like Housing First, these provide overwhelming evidence that they can make a difference in people's lives. So why wouldn't you want to use those examples to shape future policy? I was hearing about policy in Portugal and Lisbon, where government have now really supported a real drive for Housing First, which within a matter of months will create hundreds of opportunities for individual people. That's the type of responsive change that I think is needed, David, in a world that often, you know, pushes against that. But again, I think where there's a will, there's a way, and where there's learning, there's opportunity, and where there's opportunity, there's change.
Thank you. Going back to sort of the general point, Mick, if, you know, in the prison service, you know, lots of stuff. I know you were talking about, you know, some of the prisoners actually found the environment during lockdown preferable to sort of the normal routine. How do we sort of try to embed some of that?
Well, I think one of the main lessons was the user voice is strong and far more informed than the governor of the prison. And we need to listen to people more. And we often make assumptions about what people want, and it's very rarely on the button. The other thing is there's no such thing as it can't be done. That was the second lesson of the pandemic for me. We released 130 from my prison over the course of 2 weeks, early, before their sentence expired. And the community services responded very quickly, and they were able to provide accommodation and support. Whereas we were trying things like that before, it couldn't be done. The other issue for us was the digital strategy. We struggled in Scotland in the dark ages of the digital world. And we then pushed through that because we had to respond and provide people with access to family contact. We provided mobile phones. It didn't work out quite so well, but it made the point. And I think the final thing for me, and I've always had this view, is if you want to do something, take a risk. And if you want to take a risk, never ask for permission, just go for the forgiveness.
A risky but important lesson, maybe.
Yeah, I'm not so. I will speak English because I can see that none of you has taken. My view on what has happened during COVID time is not so enthusiastic because you are coming with the good examples, and I could see over these last 2 years, I have visited different countries with the CPT, and the way how the system was functioning, it was in some countries exemplary, very good, but then you saw also that it has been very terrible, that had a very bad impact on the daily life of prisoner, because the contact with outside world, with the families, was completely cut. They didn't have visits. They didn't have contact via Skypes or this kind of equipment. What it is easy to use. They, in some countries, when they have this illegal object like mobile phones, and there are countries, even in EU, where there is more mobiles than prisoners in one prison, and I know and I'm aware of that, and that they could keep the contact. But there was no really good prevention tools. There was no, that nothing happened like that the prison population got less, or they had been given some disinfectant, or even the prison staff was wearing masks in the contact. Nothing like that. In some countries, it was working very well, and in some countries, very bad. And I think there's a time where the good experience should be shared. And my observation is that in the countries where the healthcare provision is very much linked, or is provided by the National Health Service, or they are linked to the outside, to the healthcare providers, those ones from the civil society, they are much better off. In those systems where you have the healthcare provision in the hands of the Ministry of Justice, and they are really there are walls between them and outside world, this was not working so well, unfortunately. That means I'm pretty sure there are some countries where they can share and there can be good examples, but it's not always the same.
No, it's a good reminder. I think while you've got the microphone, Marzena, there's a question here directly relating to your presentation. Do you think it's the best way, the only way to sort of improve healthcare provision in prisons? Does it have to be by the legislation? Is it driven by the law? And I guess there's a question there, you know, I might not be allowed back in the country for non-COVID reasons saying this, but there's a lot of things that are legal in England which don't happen. You know, the law says this should happen. However, in practice, it doesn't. And I just, you know, Is changing the law the best way to improve healthcare provision?
But, then if you have a country where there is a law and nothing happened, but at least these citizens, prisoners, they have to complain on something because you have. But if you have a country when there's no law and it's very soft and you can't really rely on a law, then you have no chance. You have no rights. That is the problem. And also, I think we have been struggling for many years discussing on the forum of WHO, Council of Europe, the issue of governorship over the healthcare provision. And there is a trend that it should be with the Ministry of Health, because they are those ones what they know something. And the latest development with the Finland, I think this is the last country what has been removed from the Ministry of Justice, the responsibility under the healthcare provision, proves that you can have a really good, successful model. It shouldn't be done in a hurry like it was done in other countries, then it has been done by the decision of parliamentary or government over the night and they are not prepared. I was following what has happened in UK. It has been done over 10 years. There are still traps, and I know very well it's not working so good as some people are saying, but you have some ideas you can work with, and you can have you can adjust, and you can remove those mistakes what has been done. But at least you have some concept. In many European countries, this does not exist. They have a very bad provision inside with almost no staff, and I'm not talking about some marginal countries. I'm talking about EU countries where they have no doctors and they have no nurses and they have not even one bed for one prisoner. And I'm talking about EU country where the concept of the person who is placed by the national authority to prison should have at least the state is obliged to provide one bed for one person, and it's not the case now in the 21st century. I'm sorry.
No, it's a good point, and the law can be useful. I know there's a question in the room, and I'll be in a lot of trouble because I didn't let go on or ask a question yesterday. So please, the microphone is yours.
Thank you. I'm Anna Dovbach, Eurasian Harm Reduction Association, and I need to add, and thank you very much for this division of the systems and this philosophical talk about how systems react in emergency situation. And it seems like in emergency systems go back to the basic settings and becoming those without any wishing to be nice. And what we see in our region, we are working in 29 countries, that the systems which are built on repressive mechanism, they became more repressive. And everything which we developed with the human rights and civil society participation just gone. And like emergency made it much worse. And I need to add some words which we are dealing with in the a bit more east from here. We are dealing with not just shrinking space for civil society, we are dealing with foreign agent law concerning the personal people who are speaking something freely. We are dealing with undesirable organizations, and it's very, very scaring because it's not only about one country, which is Russian Federation, but about a lot of countries around, and even Hungary could follow that. We are dealing with the drug propaganda law, we are dealing with homophobia law, and with the harsh policing because they got much more power nowadays. And actually that's, from my point of view, to add to your philosophical talks, like the challenges, but also the opportunities. And I know that we're all worrying about this, but that's additional East view, East wing. Thanks.
No, it's a good reminder of just how hostile the environment is in some places and how difficult it is for people to work. I better not forget this one, and this is particularly to you, Heino, actually, and you touched that half the Länder have drug consumption rooms. The question is about how did you overcome the resistance in the areas where you did get it from local residents, the media, and you touched upon politicians. And this is quite a live debate in the UK as well, where there's lots of people talk about possibly having drug consumption rooms, but everyone's a little bit frightened to actually set one up.
My recipe would be just do it. And I remember there was a bus in Glasgow, wasn't it Glasgow, who was supposed to be a drug consumption room. And that's the way we started. In Bremen, in my hometown, in the late 80s, we just did it. And just waited for the police to come and then to scandalize the whole thing. It was a long development, but I think from the mid-90s onwards, we did have at least 20 drug consumption rooms. But now it's getting really difficult to persuade the remaining 8 Länder, the remaining 8 states, because there's a huge blockage, and we have to face the very old arguments that drug consumption rooms lead to more drug consumption, or all these ideas, there will be more higher mortality and so on. But this shows the variety of our country. It is very heterogeneous from north to west and from north to south and east to west. And now we are facing the conservative bloc still. But I think there's movement and also an opportunity. Once, let's say, one state is starting with a progressive, innovative approach, the others have to deal with that. And this is the chance of a federalized system in a way that, let's say, not everything has to go via London or via Paris. So there's more diversity in the country. There's more movement possible. But with the blockage, of course, on the other side, that some of the Länder say, no, it's nothing for us, so do it in your Länder, and that's it. But I think there's a general movement in our country. So the new government is about to legalize cannabis from next year on. So that will be, let's say, a signal for our country and also for the neighboring countries. So there's lots of other harm reduction measures like drug checking or things like that are on the way. So there's a lot of movement also now from the federal level down to the Länder.
That's sounds quite positive.
Thank you. I wish to add something to that, and actually to bring the words that Alex Stevens, we've heard from him yesterday, shared with the group at the meeting I participated in like almost two years ago. That was the last one in-person meeting before COVID. And he said a very interesting thing that was somewhat striking to me. It's in a way obvious, but then this is not what we usually do. Because he said that quite often, we, meaning the reformative side, we are in a position when we need to argue we're not going to do any harm. Where politicians, populists are saying exactly what you brought here. Well, drug consumption rooms, but they will increase the use of drugs, etc., etc. Or harm reduction is really, I don't know, inviting people to inject, etc. And then we are in a position when we need to fight back. Oh, no, it's not going to happen, it's not going to happen. So he said, why aren't you doing the opposite thing? You should be questioning, you as advocates should be questioning your politicians and making them need to provide rationale to why do we have the policies that harm so many people? Why do you, as a decision maker, allow for so many people to die because of the overdose, etc., etc.? And so actually we should turn and switch the roles, which is not super easy, but it was somewhat striking to me. Why aren't we thinking about it this way? Why do we allow to keep ourselves in the position when we need to defend, oh, no, we're not going to harm anyone? They're harming people. I mean, policies that we can see around the world, they're harmful nowadays.
I think that's a good point. Reframing the question can often make people think about their positions. And I want to pick up on some of the negative things that are out there, really, and we've heard about the problems of repressive, authoritative approaches. What are the other big threats, though? Because, I mean, one thing I'm very conscious of, you know, it's finance. But, you know, how do we get services funded? You know, and I was very struck, Martin used the word dignity. But actually, a lot of the groups we're talking about, there's a bit of a barrier to overcome before people think, well, you know, prisoners, they've lost their rights, they've lost their right to dignity. Drug users often very much the same. Countering some of that, particularly in an environment where public money is becoming harder to get by. How do we tackle that?
I'm not sure if I'm going to respond to the finance question here. I'll come back to that, but my mind immediately went to if you have years and years of oppression or negativity. I'm 57 years of age. The moment I was born, my mum started cuddling me. And almost every day since, I've had a cuddle or a kiss or a love or a warmth or a compassion. You know, so when you have, what's 57 times 365? When you have that every single day, it builds up a strong reservoir of resilience to cope with some of those life pressures that we all experience. Flip that on its side. If you didn't get a cuddle, if you have the ACE experiences, if you don't experience the love and shaping of your formative years, then 57 times 365 days of that type of existence creates a poverty of expectation in one's life. So how can we shift, going back to the dignity argument, how can we shift that to try and promote the experience for people who need services, who rely on services, where those reinforcers build up that reservoir of resistance every single day? That's not about money. So coming back to the question, that's not about money, I don't think. That's about approach. It's about understanding. It's about compassion. It's about, you know, all of those things that I think you find in good services. There is never enough money. You know, I worked for 3 years in the UK's National Lottery, where we gave away £600 million a year. But it's a drop in the ocean to the resources that are required in public services. But to civil society, it was the key lever to make things happen. You know, so it's not always about money, but I do understand the point.
No, you know, there are resources other than cash, and yeah.
Just quickly, you send less people to prison, you'll save a lot of money. As a key message about Scotland's incarceration rate is higher, the highest in Western Europe now. We're not any more criminal than other areas. I don't know why it's so high. But what I do know is there's real vulnerabilities and real inequalities in Scotland, that if we resource them properly, we've got a fair chance and a fair wind behind us to do something different. And we all know in kind of recent years, the last 10 years, austerity doesn't work, and austerity makes things worse and creates greater inequality. So it's trying to figure out about where do you take the risk to invest and then relax about the dividend that will pay eventually. But people want return on investment and people want things measured. And I don't think that's the route to go.
Thank you. A point that's been touched on there, and I'm picking up on your point about it not all being driven by money. And, you know, again, using UK example, we have a bit of a leadership deficit, you know, around a lot of these issues. And I think it links to actually some of the points here. Lots of alliances, network groups have ceased to exist. You mentioned the Frankfurt group. There was an opposed group that I seem to remember that the City of London was one. You know, European Cities Against Drugs. But, you know, despite their policy, those networks have largely disappeared. And certainly in the drugs field in the UK, lots of the sort of second-tier groups that brought people together to discuss things, they went quite early in austerity. They were seen as easy things to cut. They didn't really matter. You know, they organised conferences or whatever. But actually they provided a big role in leadership, providing a platform for people to say this works and to share ideas and informally in training. how do we reinvigorate, I guess, civil society? How are we going to make it better?
If that was so easy. But I will actually stick to this idea of going outside of the usual bubble, and because I think that, you know, it's not only about money, of course it's about attitude and a lot of values, but on the other hand, well, people who deliver services, they need to eat as well. If we want to introduce e-cigarettes, we need money to buy them. So to some extent, you can do a lot of things with your goodwill, but you come to a certain point where resources, including the financial resources, will be needed. And having been engaged for a while on the donor's side, I'm somewhat worried, to be honest. And it's not about the bad will of the donors, not at all. It's just that there are more and more needs. If we observe the space for civil society to be shrinking and a lot of human rights violations, we'll see how many institutions, organizations, and causes needs to be funded. If we look quite broadly, we have it in the description of this session, of problems such as climate change, increased migration. This is what we are observing on our border, Polish-Belarusian border, humanitarian crisis, actually. So there are more and more needs, and it doesn't mean that there are more and more funds. And competition has already been a struggle and an issue among the civil society groups. So my thinking would go into the direction of building alliances and going outside of the usual bubble. It will be difficult because we'll be competing with each other. But on the other hand, I'm afraid if we don't do that, then we just stop existing at a certain point. So maybe, I don't know, maybe to the conversations such as this one about the city health, we could invite people who work on the mental health at the city level. That's my recent engagement. On women's rights, etc., etc. Sometimes it may feel, well, but we do not have that much of a common. But we do. There's a huge overlap that we're just missing. And maybe jointly it will be easier to convince society, to convince decision makers to apply for the money wherever it's possible. So I think my thinking would be going into that direction, although understanding it's not super easy.
Heiner?
Yeah, thank you very much, Magdalena, for these thoughts, and David. Yeah, I think the civil society organizations, they are now in an obligation to really get into harm, what I would call harm production, what the government, the law, the repression does. And we have to very thoroughly scrutinize the damaging effects, the harms that are produced by the law of criminalization and so on, and thus, let's say, mirroring this damage to the society. And this needs, on the one side, activist practitioners, but on the other side, scientists as well. So I think this mixture, this combination is needed in order to mirror back what is being, what I would call, yes, harm production. Just an example, for 8 years by now, we're doing an alternative drug report, alternative to the governmental report. And we are releasing it every year, and it gets more attention than the official drug report. So we took the monopol, we took the monopol from the drug commissioner of Germany back and say, look, it's not your monopol to show Germany the situation of drugs with your political, let's say, often right-wing attention. So we take the issue in our hands and present to the German audience what we think is the real drug problem, and that is the drug policy. And so far, this is one example of how we can work, let's say, against harm production in order to do harm reduction.
There's a thought.
Yeah, I also think that the civil society should not take over from government, should just try to make the governments and different authorities accountable for what they do. And it should find a way to inform society what's going on. Because, as you said, there are many of different, on the national, city level, different people with different agencies, what they should the job. And they are not doing simply. It also applies to prison service in many countries. That means the civil society should take a role not only to advocate, but also to try to make them accountable for what they are not doing, what they should do, what they are paid for. Because the very simple example what I would like to tell you. At the time when I left the Polish service in this healthcare office, what I was leader of, there were 5 people there altogether. Now they are 20. And they do not provide even one training over the whole year for the healthcare staff. What they are doing there? That means you have a lot of this kind of example from the national level, from the city level, that they are special agency, the people are paid, but they are not provide the service. And they are not even giving a report to the society what they are using the money for.
The point I was going to make, and it picked up on Magdalena's point, I often feel that work done with these populations we're talking about is somehow not valued as part of the general sort of, all politicians, all agencies, health is a good thing, but this work doesn't somehow often seem to count. And I guess I'm looking at Mick thinking, I'm kind of aware that often what happens in prison isn't really seen as sort of general healthcare, but when you look at some of the data that's collected, the populations you have, that's where you can make your big improvements in life expectancy and healthy years. And I just, how well integrated do you feel what the work you do in prison is with what happens when people leave prison?
It's difficult to continue. What we find is the guys that come into prison are very chaotic. They're not engaged with lots of services outside. They don't ever see the dentist. They don't see a doctor if they can help it. When they come into prison, they get access to these things, and they do tend to take advantage when they're in and use them. So prison can make people healthier physically, perhaps not mentally as well. It's a difficult place to be in. The connections to the community are always difficult because there are many routes out. There's technically one way into prison through court, but there are many exits from prison, and there's not, I suppose, a consortium of support. We worked on something a few years ago in my last prison, and we come up with a kind of a co-produced product for prison officers, for through care staff, to provide a direct entry route out of prison. It was very successful until the funding was pulled. I don't know.
Yeah, it was one of the best projects I've worked on, actually, to be honest with you, because it was a true co-production. But in essence, all we were doing was thinking about the prisoner's exit on the day of arrival. It was starting preparation for through care at the moment the prisoner was received, really. Maybe not at that most immediate moment, but as soon as possible thereafter. And I think the beauty of that service, was about a continuity in approach and consistency in approach. And it was a multi-agency. It was delivered by a number of agencies. However, it became a model that became competitive among other agencies. And the system created the behaviours. So the system would want to deliver a contractual agreement with civil society agencies to deliver the service. And then people compete with each other. So the conditions will create the behaviours. If the conditions are about collaboration, which is the point I was making earlier, behaviours will be about collaboration. If the conditions are about competitiveness, then behaviours will follow. And that's the way money flows. And that's a bit of a shame.
Yeah, I think the competition between agencies rather than cooperation is a major thing. We're coming towards the end. I don't know if anyone else wants to ask a question. Raise your hand and wave it vigorously if there is. I'm going to ask the panel, and I'll give you a few seconds to respond on this, but as we come to the end, I want you all to come up with one thing that us, the Global Public Health Network, people who are watching this, can do to try to improve the situation. And hopefully that we don't only rely on humanitarian disasters or other crises to actually find, you know, that how we improve work and embed it. Because I'm very, very struck from what I've heard here, both acknowledging there's a lot of risks and lots of awful things obviously happened in the pandemic, but we don't have a repository, we don't have a resource where we can put all the good things at work and point them and say, this is what we should all be doing. I guess personal experience here, you know, watching the drugs field in the UK for 20 odd years, I'm not seeing the same ideas come around the second time, I'm now seeing them come around the third time. Some of them are good ideas that we used to do and people are saying they're brand new. And we've had this cunning idea. Some of them are disastrous and people think that they'll try to give that another go. It didn't work in the 1990s or the 2000s. I don't think it's going to work in 2021. So, I don't know who I should pick on first. I think, well, Martin, you looked at me, so you'll do first victim. What's the one thing?
I'll be very quick. Build on good evidence-based practice.
Nice, non-controversial. Of course, there is where you store the evidence base and who has access to it. I'll start trying to. What would you like to see? What should we all go home and do when we leave Warsaw?
I think we should always, the lessons are never learned for good. That means there are new people coming, maybe with new ideas, but they are not aware of the old ideas, what they were 10, 20, 30 years ago. And I think this kind of teaching between the generations of these different lessons, I think is very important for the future.
Thank you.
To develop.
We're going to close all the prisons, Mick, and no, come on, would you?
I think it's to try and make decisions or take risks before a crisis hits. Because we always do it when a crisis hits. I mean, sometimes are quite successful, but you should never wait till the crisis before you take good decisions. I suppose that's the message.
Yeah, good point. I know.
Yeah, the city level is important, and to work on that, my suggestion would be in the drugs field to reset it and to build a network of cities in the tackling of the drug consumption on the one hand. But again, I think it needs to get back to the federal level where the legal decisions are being made. And for more than 30 years, I'm now working against this criminalization and for decriminalization. And I think this is badly needed to work more thoroughly, intensively on the harm which is being produced by the repressive drug laws.
Thank you. Magdalena.
I've got 3.
Okay, if you're quick.
I'm quick. So first, solidarity. I'll keep repeating that within the movement and with others, like quite broadly in the civil society. Let's be brave enough and courageous enough to think outside of the box and, as it was said, propose novel solutions before the crisis arise. And then Heino spoke about what I wanted to say, like think globally but act locally. It's sometimes way easier to work at the municipal level.
Thank you. Well, I think they're all good points, and I better do this given it's a City Health conference. And one of the points of City Health is to try to break people out of the silos and give an opportunity for people, you know, not just to talk about drugs or mental health, but put it in the broader context. And I think that's something we'll definitely carry on trying to work to do. And the Global Public Health Network does provide a framework for people to share information and also perhaps work on just giving things a go, being brave enough to experiment a little bit. We've now come to the end of this session. You'll be pleased to know you've earned your coffee break now. Please be back here at 11:30, but before that, please join me in thanking our presenters for this session this morning.
Good morning again. We are beginning the session about digital services. My name is Piotr Toczyski, and I am not directly in harm reduction sector, but closely. And my pleasure will be to introduce to you three speakers from three geographical areas. They will be talking about three different parts of public health connected to harm reduction and digital services, and then we will discuss. Maybe we'll also have some discussions in between their talks. So the first speaker will be Jamie Trout, who represents the digital part of Simon Community Scotland, the country's largest provider of homelessness services, with outreach and residential services across Glasgow, Edinburgh, Perth, and central Scotland. And Jamie will be our first speaker. Then Ghana Dovbak, whom I will present later. She is here with us in this room. And third, another online connection with Chimemwe Ngoma from Malawi. We hope that the connection will be good, but we have it pre-recorded, so you can be sure that at least we will be able to listen to experiencing homelessness to the digital world.
Hi everyone, can you hear me okay? Is that okay? I'm going to assume yes. So, my name is Jamie Trout and I am the head of digital at Simon Community Scotland. We're a homelessness service provider, and we spent the last few months working out how to connect people who experience homelessness to the digital world, and our Get Connected 100 project did exactly that. So to give you some context around the Get Digital Scotland programme, we are a digital inclusion programme, and we work with providers across Scotland, and we look to integrate digital inclusion at the core of homelessness services so that organisations can help people experiencing homelessness to get online. Sorry, the slides are moving a little bit slowly here, so that, hence the wait. But the background to the project is that at the start of the coronavirus pandemic, we gave 36 people experiencing homelessness a digital device and connected them to the digital world, and we had extremely positive results. So we shared that with the Scottish Government, and they then funded us to roll this out on a bigger scale to do the Get Connected 100 project. We worked in partnership with organisations across Scotland, in Edinburgh, Glasgow, Perth, Fife, Aberdeen, Dundee and Ayrshire. And we trained all of their staff as digital champions so they could help to fold in digital skills learning with the people that they support.
Basically, Ghana is based in Lithuania. So let's give floor to Ghana. Thank you for coming, and then we will return to Jamie's presentation.
That's a big honor for me to speak to you and actually to present what we did together in the consortium. And honestly, being a psychologist and social psychologist, when all this pandemic starts, that for me was sensitive deprivation, absolutely. So I couldn't work with the screens. I need to hug people. And that's why when we analyzed what is happening with the harm reduction services in Eastern Europe and Central Asia, together with the members of association, and we have 29 countries and more than 300 members providing services, I felt the same frustration from our members in the field. They are locked down, they are in the situation when they couldn't move in the streets, and their clients, our people using drugs, are on the streets or somewhere hiding. And we all were forced to the online services, but with online or digital services, we understand absolutely different types of services, because for some of our key populations, because we did this together with the ECOM, which is network working with the MSM and transgender and providing services to them, together with the Eurasian network on Women's Network on AIDS. So that's different populations, different groups, and different people. And in digital world, we are living in absolutely parallel worlds. And the task, what we had, hopefully it will work. No. I like this digital stuff. Oh. It does. So I will go very quickly through the assessment we did together with the research team to know what is happening and do we have the best practice to base our next development on, knowing that how different we are. And with the research, we understood that we are placed in the position when we couldn't do how we used to do. To hug, to consult, to spend time together. And that's concerning not only counseling, but also supervision and self-support. And you know, all the world closed now in the screen. The small one with the telephone on the bigger with the computer. And we needed to discover what's happening on the ground with the services, where we are there. And actually, we conducted the mapping of what is happening in the ground in the organizations and also described the best practices, because there are a lot of practices of connecting different services. Mobile clinics were delivering OST and antiretroviral therapy to people who couldn't move from their homes. And connection between different services and self-testing at home. And so it's just incredibly fast developing area of work. And we needed to know what doesn't work well, how we as regional networks could support our service providers in the field. We developed the methodology, our team, research team developed the methodology, and we asked more than 50 organizations in the ground with the in-depth interviews and searching what is happening. Even 60 respondents were there. And going to what we found in the research, you see that the range of services provided online or digitally or distantly is huge. Almost all services went online. That's what is happening all around the Eastern Europe and Central Asia. And what we see, that actually people start providing services, and that's what wouldn't stop with the pandemic. So we will be in this online world. And I could imagine that there will be, for ages, online conferences, online services, and all will be digitalized more and more. But in the same time, we have already good experience. We have something to be placed on and to start with. And actually, we already have some standards of quality standards and some approaches how to do this in a qualitative manner. And that issue of quality of services is the most important for our region. We are transiting from the international funding to the local funding or to domestic funding, and that's why the question of the package of services provided and the quality is the most important for our region. whether it's provided digitally or not. And we all understand that digitally we are even more vulnerable to different security issues than in the physical environment, in the face-to-face meetings. And what other issue that we all lacking, and social workers and field workers were saying that we're all lacking knowledge, understanding, protocols, algorithms of digital or remote services. We're all developing, inventing the same wheel in our workplace. That's what happened with the COVID. And one of the issues which also, maybe it's very specific for our region, because we have centralized system of monitoring and very bureaucratic system of monitoring coming from international donor reporting, but also from the national reporting. But a lot of social workers felt abandoned or left apart from the usual reporting. When you are spending 40 minutes counseling person, or when you are taking person to the hospital, and that's case management, and supporting the client with a lot of services in a way, providing this support and all possible knowledge and skills you have, then you feel yourself valuable. But if you are just sending SMS, please go to get RT, then it's a very strange feeling, because all your skills of social support and social care, it's like not used. And sometimes when we are introducing online automatic services with this SMS and reminding, or some chatbots, some system answering the standard questions, then social workers feeling, are we needed? Or maybe we will instead of harm reduction, we will have vending machine and chatbot, and that's enough. Is enough? Or maybe people need for their safety, for their quality of life, for their social security, and actually being well in the social community, in the local community. Do they need us as a social workers? And maybe it's a bit reflection from the previous philosophical session, but that's very important for us question on the quality, on the accounting the work and effectiveness of our work. And what barriers we found? Funding. And especially when it's online, it's very hard to touch, to see, to monitor, to go to see. This is the client, this is the social worker. And we are struggling with the sufficient funding for ages, but now it's even more, and we expect that with the COVID crisis, we will be less and less prioritized for the local funding. Training and adaptation of the methods for online services, and adapting staff and specialists for online services, but also systems. Cybersecurity, that's a question, and we had no tremendous broke out in this area, but we could, because majority of contacts are going on in the Viber or in Telegram and through the real telephone of people. Professional burnout. I felt it by myself when I'm with a screen at home in my room for several weeks, and we all experienced it, being social animal. It's just, lacking the support we used to have during such conference as this, and used to have through psychotherapy. Yes, we have COVID problems with the social service and, again, restrictions. So we divided all the needs on the groups, and we had some technical needs, and that's where we started advocacy for those who are funding the services and managers of the organization to include the technical needs in the budget. And that's very good that Global Fund and Robert Carr Network Fund, they are providing this specific COVID support to digitalization of the services, to procure all needed technical tools for this stuff. And that's where we are now developing knowledge and skills and approaches for staff to be trained, and all of staff in the region, frontline staff, counselors, outreach workers, peer workers, need to get some basic knowledge about this. And as for financial, it's clear, but also the systems of reporting, of accounting the services, of knowing the impact of the services and assessing this. That's where we are now. And yes, we described several services which exist already, and you could see them online in Russian and English, and there are plenty of them. And vending machines are already in the region, in Georgia and Moldova. There is remote HIV counseling, there is the web outreach and chatbots specifically for such groups like the trans people and MSM. But we are developing for the people using drugs, specifically new psychoactive substances. There is the first signs of telemedicine. So we have something to share and good description for managers how to use it, and for the advocacy and work. We're really keen to go on with this, to ensure security, to ensure skills of social workers and frontline workers in our region. And we have plenty of tools to develop and plans to fulfill. But that's what we are developing now. It's a training course on effective online counseling, and team who developed this training course is here in the room, and we are happy to cooperate within the Europe to get all the best experience for this course. And now the piloting group is working on this, but also important part of work is psychological supervision and psychotherapy for activists, and that's already provided for several groups of activists. Specifically, like if you burnt out online, you could get support online. that's a tricky situation, but that's how it's working now, and it's really working. Surprisingly, it does. And security protocols for staff and for clients, and maybe it sounds very, for technicians, they will say, okay, everything is here, but not for us who were in the previous life, before COVID, before pandemic, were going on the street, talking to people, bringing them needles and syringes, supporting them in getting medical help. And now we need to do the same in online services. So that's where we are. Actually, that's one of the important topics in line with the quality of services and package of harm reduction services, and even defining what is the harm reduction, a part of HIV response. We have plenty of questions within the Eurasian Harm Reduction Association, and I'm very happy to discuss some of them here in the conference. Thank you.
This short exchange will continue later during our debate after we have all presentations done. And now we are getting back to Scotland, which got digital. So Get Digital Scotland again with Jamie. You can stay here or move. That's your choice.
Go. Hi everyone, hopefully you can hear me again. I'll start from the beginning. I'm not sure how much of the last presentation you heard, but my name is Jamie Trout and we've been running a digital inclusion programme in Scotland's homelessness sector. And we connected 100 people experiencing homelessness to the digital world. To give you some context, Get Digital has been looking to work with people, organisations across Scotland to help people who are at risk of homelessness or experiencing homelessness to find ways to get online and benefit from everything that's the internet and the online world has to offer. Yeah, back at the beginning of the pandemic in March 2020, we developed a program called the Get Connected program, and we gave 36 people experiencing homelessness a digital device. And then the data that we collected from an evaluation of that project showed extremely positive outcomes for the people that we support. So we presented that to the Scottish Government, and they funded us to expand that further and deliver the Get Connected 100 project. It was delivered with our partners across Scotland in Glasgow, Edinburgh, Fife, Perth, Aberdeen and Ayrshire. And the model that we used was we gave each person a digital device, a SIM card with unlimited data, support from a trained digital champion, and a framework of digital skills that would be most relevant and useful for people experiencing homelessness. In terms of the device, we offer people a smartphone or a tablet, and about 4 in 10 people chose the smartphone, and around 6 in 10 people chose the tablet. In terms of data, it was an unlimited SIM card. We wanted people to be able to use all of the digital tools available to them, so video calling and streaming. So we didn't want to give a limited amount of data. We wanted people to be able to try and learn and explore all kinds of digital tools and have the access that they want and need as and when it's needed. We didn't want people to have to choose between contacting their doctor or contacting their family, so they can just do everything. In terms of support, we trained frontline staff in all of our partner organisations in how to fold digital skills into the work that they were doing on the front line. And then we also got those digital champions to set up the phone with a Google account. This gave people access to the Play Store, so all of the apps and tools that are available online. I'd also set them up with an email address, which was really useful for keeping in contact with people. We also set up and customized the device, so things like setting them up with their Wi-Fi, setting them up with passwords and location settings and privacy settings. And we trained all staff in how to embed digital inclusion into the work that they do. And finally, the framework was based around 4 key areas of digital skills. So connecting with people and organizations, that was things like emails, messaging, video calls, accessing reliable information, so how to search for information online, but also to access the National Health Service that we have in England and Scotland, and also to access the news and get the latest news on coronavirus updates. We help people to manage finances, so online banking, online shopping, also looking at things like accessing benefits from the government. And the final category was entertainment, leisure and learning. So being able to listen to podcasts on the radio, watching films, reading books, meditation, podcasts, all of those kinds of things. So this is a very strategic and integrated approach. We found that without any one of these key things, the project wouldn't work. People obviously need a device, and they need the connectivity, and they need the support to be shown how to work, to use the device. And the framework of digital skills was really important in guiding people and letting people know what is available to them. We handed over the devices to the 100 people experiencing homelessness on the 1st of March, and the results were extremely positive. We completed an evaluation process 6 weeks later to try and understand what difference it had made in people's lives. 69% of people responded to the survey. And I'll share with you some of the evidence and results that came back from the project. So first of all, we had 92% of people felt inspired to learn more. 92% of people felt more confident with digital. 94% of people will continue to use digital. 91% of people increased their use of digital tools, and 98% of people found the digital champion support helpful. We also spoke to the people who were supporting the people experiencing homelessness, and our digital champions said that 85% increased their support, and I think it was 100% of people had said, of staff said that the lives of the people we support had been positively affected. So how did people use those devices? In terms of connecting with people and organizations, 96% of people in the project use digital to communicate through a range of different tools. So whether that was WhatsApp or social media or video calls or email, 88% of people felt more connected, and 85% of people were able to access more support. The reflections from the service user really showed that being able to connect with friends and family during the pandemic with their digital device had a really positive effect on their life. Also, being able to find reliable information was essential to people. 92% felt more informed, and we had 70% of people accessing government information and just over half of people accessing health information. Again, the reflections really showed that people could find out the information that they needed whenever they wanted, whether that was updates around COVID, the news, the weather, or completely varied usage, but just being able to look and find information as and when they need it was great. Over half of the people were more in control of their finances and were able to purchase things online. The thing that really came through with that was that people were able to also manage their own benefits as well. So being able to access, in Scotland we have universal credit, which is available for people experiencing homelessness. And the fact that, not just the fact that they were able to manage it, but they were able to do it themselves as well. There was a lot of outcomes around independence and control as well. In terms of well-being and entertainment and leisure, 96% of people accessed online entertainment, and that was through a range of different tools such as streaming videos, gaming, and audio streaming. But the thing that's important to remember here is that it wasn't just about watching YouTube or watching movies online. A lot of the time, by having an escape to be able to do something that's in leisure, it's actually a distraction from falling back into more destructive behaviors as well. We also found that the framework that we use can be entirely flexible as the internet is. So if we want to help people to, to start living a more healthy lifestyle or to focus on health, we could help people by helping them to access health eating apps or to register with a doctor or to install step counters on their mobile. So digital can really kind of be very flexible to focus on whatever goal it is that people want to achieve. And there were 10 life-changing impacts as well. I don't quite have time to look into these now, but if I direct you to the Simon Community Scotland website, we have a full report around these outcomes, and there are success stories and examples and case studies of how people were able to increase their life opportunities and basically improve quality of life. And the one phrase that we heard over and over again, we conducted interviews with about 30 to 40% of the 100, and it's been a lifeline. It's the one phrase that we heard over and over, that having access to connect with family or access the services they need, or being able to buy something that they need during a lockdown situation, being able to find out what the latest laws are around social restrictions, that it was an absolute lifeline for people. And One thing that we've noticed in the homelessness sector is that a lot of organizations tend to focus on working in inclusion. People experiencing homelessness are often excluded from many parts of life. But the thing that we've noticed is that it's not just digital inclusion, it's not just a type of inclusion. There are lots of other types of inclusion as well. So social inclusion, there's health inclusion, financial inclusion, democratic inclusion, educational inclusion, inclusion in public health services, and cultural inclusion. But what we notice is that digital inclusion isn't just another type of inclusion like many of these things. Digital inclusion is actually a pathway to all of these other types of inclusions. It's a catalyst to help people reintegrate back into society so that people can contact their friends and family, access the health service, manage their finances, being able to vote and other types of civic participation, to enroll in university or college or sign up to an online course, and to be included in public services and to be culturally included as well. When people are digitally excluded, they face exclusions in all of these other areas, but by connecting people to the digital world, it opens up and helps people to reintegrate into society. So digital inclusion doesn't just include people in digital, it brings them back into society so they can access all of the other benefits that people in our society who are included benefit today. And that's about it from me. I'm looking forward to having some questions and discussions later.
So it's time for one or two quick questions before we move to another presentation. If anyone has something to say, I'm monitoring the room. There's one question. Yes.
I think what we've heard in the last two presentations shows how we can use digital formats, digital platforms to innovate. I just wondered what the two people who've spoken so far might think about how additional digital platforms can be used in things like housing support or friendship connections or connections back into mainstream services, those types of things, because I think when there is financial pressure on services, digital platforms provide another opportunity perhaps to do things a bit more differently, but also things a bit cheaper too.
So this was a question to Jamie, I guess.
That's a really interesting question. I mean, it's one thing that we kind of focus on a lot is looking for opportunities that digital can bring to services. To give you a couple of examples of the things that we've been looking at a harm reduction app. So bringing together all of the harm reduction resources that are available across the internet and compiling into one digital platform that can then, that ties in really nicely with our Get Connected projects, because we can then pre-install the app onto the phone so that when someone starts using the device that we give them and they have a trained digital and harm reduction champion supporting them, they have access to information around wound care, around overdose situation, around naloxone, and lots of other issues surrounding harm reduction and drug use. So that's an example of a digital platform where we can hopefully bring more information to the person that we're supporting. But yeah, I mean, there's tons of other examples as well of people certainly in housing, of people being able to moving into when people move into housing, they often can feel quite isolated from leaving a temporary service and then suddenly going into their own house and they don't have people around them. So using digital to try and help people to meet up and rejoin communities to maybe to find buddies who've also just experienced the same thing. So yeah, but the one thing that it kind of all comes back down to is connection. We want to try and help people to stay connected, and digital, I think, has a huge role going forward to help us do that.
Thank you. And Ghana has one comment.
Yes, I have one question actually to Jamie. It is about the ID and access to state services, because we living in Lithuania. I know that the key challenge to assign for vaccination or to get the vaccination certificate or to connect to any state services is the first, you need to have national ID, and the second, you need to have bank account to access the system. And that was the key challenge for people who don't have national ID or don't have the skills to get connected through this bank identification codes. And that's, I saw how complicated it was for people who are not working online, who are not all-time connected, and how big barriers this created just because we connected. And I know that Sweden has experienced the same. With all this COVID vaccination, medication, and all this, we created an army of people who are out, once because they could have no national ID, and second because they really have challenge or no bank account or no skills to get in this online banking to have identification. Could you explain, did you have this experience of helping people with this?
Yes, we absolutely did. The people that we support experience homelessness, and not only are they the most digitally excluded group in the country, but things like IDs and bank accounts are also really hard. And the reason is that there's higher barriers for that. Quite often to get ID or a bank account, you need to have a permanent address, and people who experience homelessness don't have that. So there's almost this self-perpetuating circle that you can't have. But we've been looking to try and develop partnerships with banks so that we have people from the bank who come into our centre on a weekly basis and try and sign people up. And it's actually been quite successful, but you will notice in the Get Connected presentation and in the report that signing people up to do, there's the 4 categories. So the connecting with people, 96% of people connected with people online, and that's because there's low barriers. Anybody can sign up to an email address, anybody can sign up to WhatsApp or social media, relatively low barriers, and it's free. Whereas with the banking, it was just over half, so we had 52% of people were able to use online banking services. And the reason that that's a lot lower is exactly those barriers that you're talking about. You need to have ID, you need to be able to go into the bank, they need to send you a letter, you need to have a PIN code. And when you've got a population that's quite transient and living a chaotic lifestyle, it is very difficult to try and get people who experience homelessness to cross those barriers. So I absolutely accept your point. That is a real difficulty that we face. In terms of vaccination, very similar, like really difficult to try and get the documentation around that. But what we were also able to do was develop partnerships with the health service so that they will again come into our centre. It was actually on a daily basis, and give out vaccinations to people experiencing homelessness as well. But it's I think it's something that needs to be done on an organisational level, as in building partnerships, rather than leaving it up to individual staff members or individual people experiencing homelessness. I think it's something that, as an organisation and the government and the health service, can actually look to work together to make these kinds of processes easier, so the barriers aren't as difficult.
Okay, so after those short exchanges, we will be moving to another presentations. Just one highlight: I appreciated that 99% of people in those surveys mentioned that they appreciated digital champions, who are named usually proxy users in internet studies, and it's good to know that you can access internet even if you don't access it. Actually, you can ask someone to help, someone to show you, and so on. But let's move to the third speaker, who will be Chimamwe Ngoma, who is a social scientist, tobacco harm reduction advocate, and project manager for THR Malawi, which is an information dissemination project on tobacco harm reduction and nicotine science in Malawi. And Chim has worked as a content writer consultant at Solimar International and as a project officer at Drug fight Malawi as well. His speech is pre-recorded, but he will be with us and hopefully able to answer questions after what is pre-recorded. So let's watch, and this way we will include everyone and be able to summarize it. There are also some questions waiting for later. Thank you.
Hello everyone, my name is Chimama Ngoma. Together with 9 other colleagues, I run THR Malawi, which is an information dissemination project on tobacco harm reduction. And the title of my presentation is Forced Online, the Impact of COVID-19 on Tobacco Harm Reduction Advocacy in Low and Middle Income Countries. Let's begin by looking at a brief background. When COVID-19 pandemic struck, governments, companies, organizations, and individuals were forced to rapidly readjust their work. Nearly overnight, we saw governments issuing orders that limited large gatherings of people, restricted in-person business operations, and encouraged people to work from home as much as possible. Hundreds of millions of people have since lived through lockdowns. This left humans with limited choices, and we began to look for ways to continue our operations remotely, and thanks to the internet. However, as tobacco harm reduction advocates residing in low and middle income countries, transitioning from face-to-face to online environments has presented us with both challenges and opportunities. But before I share with you the challenges and opportunities, here is our experience of working online. Before the pandemic, THR Malawi had hosted a number of virtual orientation sessions for our volunteer ambassadors. We also participated in a number of Twitter chats with our colleagues in other African countries. So for us, it wasn't necessarily an abrupt shift to working online. During the COVID-19 pandemic, we were privileged to host KAC's hybrid launch of the Burning Issues report. This was both a challenging and a great learning opportunity. As one of the people organizing the event, I got exposed to new digital skills and platforms which I employ in my work today. We've also been able to participate in a number of virtual conferences, meetings, and trainings, some of which we wouldn't have participated in if they were strictly face-to-face. Most importantly, we capitalized on the shift and managed to identify and create new partnerships with other THR advocacy groups across the globe. Since the shutdown of in-person meetings forced us online, we have encountered the following challenges. When we made the shift to online, we experienced a divided attention. We noticed that the online public sphere paid much attention to issues about the pandemic and somehow overlooked any other equally pertinent topics and issues. This affected our information sharing activities online. We had to drag our activities for a while until the time we noticed that people have started to pay attention again. The other challenge is low levels of digital literacy. Effective ICT use requires e-skills or the ability to use a computer and other network sources. In many low and middle income countries, and Malawi in particular, digital literacy level is low, and thus a majority of people, including relevant stakeholders, are not able to take part in the online discourse. On the obvious, you will agree with me that making online meetings effective and interactive is another art. One has to be familiar with certain skills. On top of that, in an online setting, distractions are only one click away. For example, when we see a notification popping up on the screen or an urgent email, we feel compelled to reply to. Lastly, and specific to low and middle income countries, especially the sub-Saharan Africa, poor internet connectivity and affordability of data are the biggest challenges. In the next few slides, we are going to look at the magnitude of this challenge. Making comparison across the 13 global regions, the Cable UK shows that the Sub-Saharan Africa and the Northern Africa are at the bottom of the table. They have the slowest internet. Now, focusing on data affordability, Cable UK further reveals that the Sub-Saharan Africa region has got 6 out of the 10 most expensive countries in the world, with Equatorial Guinea as the most expensive in the world, and my country Malawi as the 5th most expensive, as shown in the bar graph on the left-hand side. A little more detail about what internet affordability means. The Affordability Index describes internet as affordable if 1 gigabyte of mobile broadband costs no more than 2% of the average monthly income. Considering the situation in Malawi and many other low and middle income countries, where 1 GB of mobile broadband costs more than 2% of the average monthly income, and an existing huge gap between affordable and recommended prices, internet affordability is a far-fetched dream. On the brighter side, online environment has helped us to discover and exploit the following opportunities. It has helped us to reach out and connect with new and more participants and partners. As Teacher Malawi, we have witnessed the benefits of going online. Our audience base has broadened up and we are able to participate in global public health conversations like I'm doing right now. Secondly, the online environment has helped our members and partners who feel sidelined in face-to-face interactions, shy people, and people who need more time for thinking things through to get more chances to contribute to the discussion. Lastly, the online environment has helped us to discover new things and we have learned how to operate certain computer and internet facets. In conclusion, despite the challenges brought upon us by COVID-19, as DHR Malawi, we believe that we will come out of the pandemic with some human features enhanced. And that's the end of my presentation. Thank you very much for your attention.
So just one question, if we are actually connected to Jim. Yes, we are. So if there is any quick question, just an ad hoc question for the presentation, that's the moment. There is one. Yes, if you could.
Thanks for the opportunity to make this question. You were talking about increasing audience. In the case of vaping and other topics related to THR, we have something that is called ban shadow over us. That means that we have no, sorry, I don't know the word in English again. We can't reach normal people. We have a block in the way we can interact with them. How do they fight the shadow ban? And also, how do they fight the very huge amount of misinformation that we have right now fighting over many areas of THR? That's 2 questions in one.
Hi, everyone. Should say that I like it that we actually have this ban by our government in order to restrict us from conducting campaign online. But I'm aware platforms, other social media like Facebook and Twitter limit us or limit campaigns related to tobacco harm reduction. So we have encountered such problems as well, but we have tackled them by telling our messages in with the instructions or the guidelines that set forth by Facebook and other social media platforms. We make sure that we don't violate those guidelines and rules by placing our information is in a way that we are within. So in that way, we are able to share or participate in the online discourse. On top of that, there are other platforms that necessarily not put restrictions on the language or how people interact. For example, if it is a training or let's say it's a meeting, in there you are free to use any word that you would want to use, and there are no restrictions. So for conferences and meetings, we don't really have that restriction, but for other media platforms like Facebook and stuff, we have to make sure that our messaging, our communication within the guidelines of, the guidelines that have been set forward by the owners of the social media platforms. Thank you.
Are there any more questions to Jim? An ad hoc question about situation in Malawi, Malawian internet, Malawian harm reduction? Okay, if not for the moment, I will move to questions from our online participants because they keep posting some questions. And there's one question to you, Ghana. You spoke about security issues. Are there also safeguarding issues to content within online service delivery? I mean, for both client and worker, this is the question from Katie Reifenberger. For both client and worker, there may be some safeguarding issues regarding content within online service delivery. It's very sensitive, of course. Speaking about health, online is always sensitive, so the issue of safeguarding is what's interesting for our listeners.
That's specifically in the context of drug propaganda, homo propaganda, and all these issues of when the clients hiding the information, and social worker need to have a trust, or clients need to have a trust in social worker. Online communication on the sensitive issues, that's one of the hardest part. And we discussed it with the social workers who are now piloting the course, and what I feel myself that even if you are not writing something, because to write sensitive content in the any chat, that's already very scary, and it's hard because it's hard to explain with the words, but with the writing it's even harder. So even if the counselor or calling the client, then counselor need to be sure that there are no one around. And we really faced during the assessment, there were cases when people shared, like the gynecologist calling the woman and describing something on her diagnosis, not asking where you are, and the woman in the transport picking up the phone. And that's also skills to say, no, I'm not available now, or no, please don't call me with this, or no, I'm not in a safe place. And that's all when we are talking about the security protocols. It's not only about passwords or keeping the personal data within the computers, but it's all basically, it's starting with the safe space, comfortable space for communication. It's all the same. If we remember the training us as a counselors or psychotherapists, you start with a setting, how safe it is for person, how secure it is, how trustful the place is, the person is. But with the online, the respondent, the listener is very right. That's the basic issue with the true counseling. And that's where we need to be very careful.
Thank you very much. And safety and security and safeguarding those keywords will be with us most probably from now on when we are approaching digital health, e-health, e-counseling, and so on. There is also a question for Jamie from Aneka Svarberg. The question is, what was the best individual outcome you were able to witness through the digital project? The individual outcomes are always fascinating. So Jamie, do you remember such one?
Yeah, I mean, I must share the Get Connected report because we talked through loads of case studies. There were a couple that really stuck in my mind. One was someone who was in one of our services which helps people who have drug addictions, and she had been in and out of the services and relapsed and in and out of the services. and she was doing really well, and she'd been, you know, I think for about a month she hadn't used drugs, and was making really big progress in her personal life. And then she had a bit of a crisis moment in the middle of the night, and her support worker only works from 9 till 5, so she was kind of alone during the middle of the night. And she said afterwards that ordinarily she would have relapsed, but because she had the device, she was able to log into a recovery and support meeting in Canada, which was obviously during the day at that time, in the middle of the night. So she managed to find herself a support group and had a video call, and she's still staying in contact with those people now, so that if she ever has a relapse outside hours, she has a support group. And that's just something that stuck in my mind, that digital offers people support as and when they need it. They don't even have to wait until like opening office hours. So the opportunity to give someone that chance to go and, you know, help themselves in that situation, I thought was really remarkable. And I have another great example if you want to hear it as well, but I don't know how you're doing for time.
You can continue, let's say, for one more minute.
Yeah, I'll make it quick. There was another great example of a woman who came into our hub, and she had a court case about custody of her children. So I can't think of a more personal or stressful situation than having to do that. But she had to do it online because it was during COVID, but she didn't have a device. So she was going to have to log in a public space, you know, with people all around her to talk to the judge around keeping her children. But just as a freak coincidence, that day the devices arrived. So one of our support workers was able to give her the device, and she was able to go home with the SIM card and log in her own space at her own time with dignity and respect, and log in, and she was able to actually to speak to the judge, and there was a positive outcome from it, and she was able to have custody of her children. So it's also not just about access, it's about access in a place and a space that's their own, so that we can, especially for private moments and confidential moments, people can use the internet. So those were the two things that always stuck with me. Sorry for taking up too much time.
Thanks a lot. I would like to refer quickly to Chim. You mentioned access issues and pricing issues regarding the internet in Malawi, but there is this debate about internet access as a universal human right, and this case shows exactly what we mean by debating internet access within the human rights framework. I would like to pay your attention to digital potential and intensivity of internet use, and I guess that your clients and your stakeholders, they are actually intensive internet users despite low digital potential, because they have hard to reach access, but they want to use it, they are eager to use it, you have offer for them, and so on. Would you like to refer somehow to this framework, because it may be interesting for many geographical regions around the world? This conference is named City Health, but even in the cities around the world, you can have very unfriendly digital, how to say it, digital infrastructure. So maybe some insights from you would be beneficial for us.
All right, thank you very much. And yes, I agree that access to information or access to online and digital platforms should be regarded and is a human right. People should have access to information, and they should have access to these digital and online platforms. But here in the beyond an individual capacity to solve, there are issues to countries with long established 4G or 5G infrastructure tend to fall as the cheaper side or the fast or good internet connectivity. If our countries or if our region can improve on this or on such infrastructures, people this side can have access to good internet connectivity, and they can use to access the information online and on other digital platforms. So, and yes, it is true that sometimes in well-established countries, there might also be poor connectivity. But when we compare to this side, I think the sub-Saharan region lags behind so much. And I think there is so much that needs to be done so that people can have access to internet connectivity, good internet connectivity, and cheaper data costs. So I think it's something that has to be harmonized. It's something that needs to be relooked at by the authorities, maybe both in sub-Saharan Africa or low-income regions, as well as in high-income regions, so that people have good access to good access to connectivity and cheaper data costs for the benefit of everyone's access to information. Thank you.
Thanks a lot. I already pay attention to several circles of internet inclusion or digital inclusion, because to be included you have to have access, you have to have skills and motivation, and also you have to make beneficial and optimal use for yourself. When we listen to Scottish examples, there were like references to well-being, that it increased well-being, but from some people who spend a lot of time on the web, we hear that it's something like the factor of decrease in their well-being, that they are digitally tired, it's Zoom fatigue and so on, digital fatigue. So it seems that we have all those spectrums of factors, and what we can start thinking of is building some frameworks of reference for our organizations to somehow get mapped on the scale, to get compared to the optimal standards. Anyway, key populations declare that it is beneficial, and we know it is beneficial. And now, when I was taking notes, give me a second, from all those speeches, something which grabbed my attention was that we have already media literacy frameworks, and businesses have digital maturity frameworks, and maybe we can borrow it from them quite quickly, actually, because they were thinking about it for decades. They were building those frameworks, and maybe we don't have to reinvent it. Maybe we just can take what already exists in different sectors. So that's just the idea. We know that we have another dimension, which is sensitivity, because health and health-related issues require greater sensitivity. But a lot has already been written down, and maybe we need intersectoral discussions. So let's have another round and see if there are more questions to our speakers. We had 3 fascinating presentations. There is one more question from Daniel Hawkes to Jamie again. Did you have much opposition to the idea handing out free smartphones and tablets to people experiencing homelessness? Were there opponents of this idea, Jamie?
Yeah, I mean, fortunately, it was something that we'd actually been delivering the digital inclusion program for about 3 years before we looked at actually supplying devices. So initially it was around helping staff to understand the importance of digital and how digital can have a positive effect in people's lives. And then when we handed out devices, yes, there would be some opposition, but I felt like we'd already broken down a lot of the barriers over the previous 3 years. But I think without doubt, there's been a change in perception. I think digital has initially been seen as a nice to have, even if you in the most positive light. Obviously, in the most negative light, there were perceptions that people, there's too much harm of being online and there's too many risks. But there's risks in taking a plane, but it doesn't stop people going on holiday. So I think it's something, of course, you've got to address those negative perceptions. And I think a lot of the time there is good reason for why people have that, but also to explore the benefits. One of the main negative perceptions we had was that people would sell the devices. And from our initial pilot, we're 12 months on and we had 36 people were given the devices and 35 of them still have it. The one person who doesn't have the device lost it, they left it on a bus, and we replaced it for them. So the negative stereotypes around device theft and selling has just not been realized. The evidence doesn't support that.
Thank you. I believe that Daniel is satisfied with your answer, but in the case something more needs to be clarified, the online space for asking questions is open. Ganna, I have a question too, because when I was reading your report, you mentioned I would say dozens of areas when you mapped what those Silica 50 organizations responded, that there were several areas of digital activity of those organizations, like from chatbots, some monitoring systems to online counseling and so on. But you didn't say much about some extra cases, because sometimes there are, let's say, opinion leaders or activity leaders, some organizations that do much more, and there are some, they are called laggards, that stay behind, but they also have their wisdom in staying behind. Would you like to refer to those who stay behind and those who move forward, those heavy users, let's say, of digital activities? Like maybe you have some free associations, some insights which could be beneficial for us when looking at this diffusion of innovation from this perspective.
I would say that it depends on the needs of clients, because there are some communities who are living online already for years. They are meeting partners online, they're dating online, they're selling sex online or finding the clients online, and it's the process which, and they are buying drugs online and they're checking drugs online. So everything is online. And for those clients, of course, when we are developing these online services for new psychoactive substance users or youth using drugs, we need to do it in the darknet or in online chats. And if we are doing, for example, services for preventing HIV or other sexual transmitted diseases for men having sex with men, all communication is already not in the pleshka, as we called it, or cruising area. It's all online already for 10 years. That's why all services need to be there where clients are. And for those clients who are using, for example, opioid substitution treatment, and they are coming there every day, or luckily in the lockdown they get take-home dosages for 5 days, they could have simple digital life. So it's just maybe chat or telephone or emergency telephone. So we are coming, we are developing services following the needs of clients. And that's why actually it's so good that in our digital tool, our colleagues suggested to personalize services, to use the tools in accordance of the digital life of people. And I wanted to answer a question it's not a question, but thinking about the digitalization and using the business approaches. For me, it's very, very much Big Brother watching you. with the business using our preferences, business or politics using our preferences online to sell something, to sell ideas, to sell products. And for me personally, maybe it's values, maybe it's more beliefs of mine. We could show that service exists, but we have no right to push for the services in a way as the business is doing this, because it should be by demand. If service is not demanded, then it's something different. At least in the psychological counseling and harm reduction, we need to give people what they really need. And the only, what I see, I had one idea once and we never implemented this, and maybe after this conference I will find somebody who could help us to implement. I know that in English-speaking world, in some social media, there is this cooperation between suicide prevention services and social media. And if the youth or teenagers type in some words in English connected with the suicide or somehow indicating these attempts, then social media shows the screen with the link to the services. And that's absolutely amazing, but we don't have it in the national languages and we don't have it in Russian and in Russian-speaking social media. And for me, that's the key. It's not a business skill. It's just emergency reaction, which we could develop, or emergency algorithm, which we could develop in the social media using the business approach, watching, checking all the words. That's how I feel it's better to do, to react on something person is sharing, if it's even if sharing with a small audience, but if person is writing something or saying something online, sharing this intention, we need to provide opportunity for help. But we could not sell our ideas or our view on the services or even our services in a way how business are selling their products.
Thank you very much. I just, when you mentioned suicide prevention, it came to my mind that if suicide is the tip of the iceberg and depression is just below, I recently had privilege to introduce the tool and website in Poland, which is named I Fight Depression. It's already available in several countries worldwide in more than 10 languages. We have it in Polish since last month, and we are deploying it in other languages as well, but there is no that advanced cooperation like predicting vocabulary in it. It's not very interactive. It's very good. It's evidence-based. It's built based on EU-funded projects since 10 years, but there are some steps which are now fostering my imagination in this I Fight Depression thing. So next question which is coming to my mind is to Chim about actually the imagination which is changed because of the internet. Because even if you cannot use the internet for some reasons, let's say government says it has to be turned off, or it's too expensive, or there is no political or economic will to subsidize it, and so on. But you know it exists and you had chance to use it. Then the key population to which we are referring has already the imagination changed, and those who work with the key population also somehow use this metaphor of internet in their everyday activity. Is your experience somehow in line with this approach, that you start imagining some services and you introduce some offline services which are somehow enhanced just because the internet is around and something digital exists which refers to your activity. How would you respond?
All right. So although we've been able to shift to online environment, we have not been able to exploit the online platforms to the fullest because we are selective. Before the pandemic, we are able to utilize some of the platforms, and in our imaginative world, we could view some platforms like, let's say, WhatsApp for our meetings with our partners or members. So during the pandemic, it was very easy for us to shift to this platform, but the challenge came in again because of expensive data costs and poor connectivity that limited our usage of the online platforms that we were forced to be using. In this case, WhatsApp, we are limited to be using, let's say, group calls and limited to text messages instead of using video calls because of poor connectivity. In this way, we are prone to fall into the pit of barriers of communication. As listeners, we are not able to see the facial expressions and gestures that were being made by the speaker. We believe that facial expressions and gestures are crucial elements when you talk about effective communication. They are useful features that complement our messages. So yes, we could visualize beforehand to be using these platforms, and when time came for us to exploit the usage of these platforms, we still faced some challenges, and we faced some limitations regarding how to use these platforms. I hope that partly or fully addresses your question. Thank you.
Very much. We have 5 minutes left and 3 more questions, and another one will be to you as well. It's from Aneka Svalberg. Do you think that advocacy in the internet age is more powerful than it could ever be prior to this level of connectivity between different people? It's just the final question to you from our internet audience, Aneka. We have connectivity problem, unfortunately. We cannot.
All right. Are you able to hear me now?
Yes. Now you are here.
Great. Thank you. So I was saying that during the pandemic, we've been able to grow our audience or reach out to so many people that we wanted to do so, as compared to if we were using the face-to-face face-to-face route of sharing our messages. During any disaster or pandemic, a lot of people rely on media platforms for news updates and any new information regarding the disaster or pandemic. So whilst they are looking for such information online, they can also easily be reached out with the other messages that let's say the advocacy messages that we create as tobacco harm reduction advocates. So I believe that in that way, we are also able to reach out to people as they are looking for other information online. Thank you so much.
Thanks a lot. And
could I answer on this advocacy with one small
story? Small story of 30 seconds.
Yes, we are all together with WHO and a lot of officials, European, gathered to meet Tajikistan Health Ministry Authority online because we couldn't enter. And they just said, oh, sorry, our minister is calling us. and they finish this meeting once and second time. So the access to decision makers, especially to the budget advocacy, to the budget decisions, they became much harder in the online world, especially in the states who didn't see themselves as an online or digital state, somehow, so they still make decision under the closed doors, physically present around the table. And being online, we are just excluded of this process, unfortunately. So this advocacy, it's more preaching to converted between us who are online and talking.
There are questions from the audience emerging. Let's quickly refer to it.
I will just have like very short comments, but connected with what was said. So we, in our harm reduction program, many people are experiencing a digital exclusion. And this is also something that is important to understand and take into account, that digital services are not for everyone, and it has to be open. We have to be flexible and needs-based service, like providing needs-based services, and also like pandemic regulations and restrictions. They were like literally connected with this also digital exclusion. So people weren't able to charge their phones and not smartphones because shopping malls were closed. So this is about people experiencing homelessness, that the access even to charge your phone, just to have contact, this is also, we have to understand all these elements that have influence on people's lives. And in a way, we came back to the roots. So because it was difficult to be in contact, just a telephone, and I'm not talking about cell phones, just like normal old telephone, we came back to the roots, and so outreach decreased the numbers and clients because we were contacting them directly and going to where they stayed, where they live directly. So this is also the other side of pandemic, the other side of digital services, and how to think about a very complex and very diverse needs of different groups of clients, and those who experience homelessness are in the most vulnerable position. We have to understand how they live and what is the access to charge their phone, and that's the best, in my opinion, that's the best example when you think about different reality.
Thank you very much. With this comment, we will be approaching to the end. One question is left online, but maybe it can be also responded online. This way we can test the digital version of our conference. The question refers to reluctance of clients to give information over the internet. This question has been approached from some angles here, so we already know something about it, but let's see if digital dialogue can be part of this experience we are having here. And so I thank you very much for your presentations. Thank you for all the questions. Thank you for your patience towards technical problems and my attempts to summarize, and we can move to the break and then to another sessions after the break. Thank you very much.
Thank you very much.
Good afternoon. It's a great pleasure to meet you all here, also in person, but hopefully there are people out there online listening to us. My name is Anna Domaracka. I am a director of the Institute for Social Studies, that is a co-organizer of this conference. And we will do our best to talk a little bit about how we are working in the field of health in the city, because city is one of our main areas of expertise and also research and interest. What is our main topic today is the healthy city. So we are using the framework of right to the city as the main axis of most of our efforts in academia, and we are trying to support the idea that both citizens and residents are the main subject of urban policies, of urban intervention, and they should be treated as the most important part of the urban puzzle. And that's why you will hear quite a lot about right to the city if you talk to me, especially because I'm definitely very much a proponent of this notion. This comes from the fact that we have quite a lot of urban activism in Poland, which is trying to support and innovate in terms of how to make our cities better and more democratic. We will have several presentations that concern specific areas that we work in. We were trying to give it mainly the angle that concerns your interests, which is health. Harm reduction is not our main field of expertise, but we will try to connect our studies to what has been discussed already. So, would you give me the, shall I click? Should it work? Will it work? So just to give you a very short introduction of what is Civil City Lab, which I have a pleasure to lead. It's a group of very enthusiastic and amazing young researchers who I have a great privilege to work with. And we've been studying different sides of topics concerning the well-being of the citizens, the health of the citizens, and how to make different processes in the city more participatory, more open, and equal to all. So what is our topic today is our way to show how the right to the city framework can be used within the topic of health. So we will focus mainly on the urban space here, because most of our present research topics and research projects concern how to change and shape and also evaluate urban space, so it would give a good impulse to be more focused and more responsive to issues like health, harm reduction, and also participation. So I would like to start with the first presentation, which will be given by Agata Żbikowska and Ewa Domaracka, and which concerns healthy urban spaces.
Hello. Okay, so my name is Agata Żbikowska, and I am one of the people who will be giving this presentation, and with me is Eva, and Eva will come in a second and change me. Okay, so our presentation is about healthy urban spaces, green areas, and well-being. Okay, and the first question that I would like to ask is who uses city spaces and how? And the answer to that question is not as simple as it sounds, as city spaces are not used by all inhabitants equally. Different age and gender groups use them in different ways, at different times of the day or the year, and for different purposes. And in a city that wants to take care of all its inhabitants, the needs of all groups should be taken into account. But right now, it very often happens that people who actually use city spaces are not the same people who design them. So this might create problems because their experiences are not the same and their needs might even be conflicting. And I will come back to this subject in a moment. So before that, I want to point out that as a result, green spaces that already exist in cities might not be fit to use. And if they are in poor shape, only accessible for the most privileged groups, or just sort of empty, for example, if they are not adapted to the needs of particular groups, like a park with not enough benches for people to sit, or no playgrounds or any equipment that can be used, their potential remains unused and they are sort of useless, really. Okay. Okay, so coming back to to who uses the city on everyday basis and why. So these are the groups that actually use cities on a daily basis in the context of green areas and spaces. So there are children, teenagers, women, mostly mothers, but not only, of course, and elderly people. And I will talk a little bit more about how these particular groups use the city spaces. Okay. Oh, sorry, I clicked the wrong button. Okay. Okay, so elderly people. They often have more time on their hands since they are retired, but less money. So they travel more on foot or via public transport. And when they are walking around the city, they need benches where they can rest. And it would be great if these benches could be placed near some greenery, which will protect them from the elements like the wind or sun. Some areas will not be accessible for them, especially if they have mobility problems, and also especially during the winter season, when leaving home might pose a big risk for them, or a risk of falling, at least in our part of the world, on wet leaves or snow. While at the same time, no exercise means that the health in these groups is deteriorating further. So they are even in poorer health if they do not leave their homes. As for women, they use the city space a little bit differently than men in most cases. They have different moving patterns. They are walking around the city, doing shopping, taking children to preschools or schools, to the doctors, visiting elderly members of the family, etc. They also need benches to take care of their children, especially when they are small, for changing nappies or feeding them. And as they are often, in many cases, responsible for the care of the house budget, some of them would find it helpful if there were places in the city where one could grow their own food. So the urban farming task could be a real asset. Okay, now for the children. Children do not usually, well, they can be driven around the town by car, but when they are moving on their own, they are using the public transport, they are going on foot or on bikes. And they also need playgrounds and parks, which should be the places where you can safely spend time, far from roads, with other children present and supervised by parents, but who are not necessarily there, but can take a look, for example, from the window. So if there is an area between the houses, the buildings, apartments, where the children can play, and the mother, for example, can watch out of the kitchen window and see that the child is there, then this is an ideal situation. And also greenery protects children, especially those in prams, as they are smaller or they are lower from car pollution and other types of pollution. As for teenagers, they also usually move around the town via public transport on foot or on bikes. But the thing that differentiates them from other groups is that they're spending a lot of their leisure time outside, walking around the city with friends, in parks, in sports facilities outdoors, etc. Both teenagers and children can benefit from green spaces in a way, because this is a way of providing them an opportunity to spend time in privacy, exercise the freedom of choice, and research shows that it boosts their self-confidence and agency, and they become more independent in the future. And one more thing, for teenagers it is really important, all the questions, all the issues connected with ecology and protecting the environment. So it is also important that we include the green spaces from their point of view in the city. And finally, green spaces and climate change. So not only do we have a huge problem in the cities with air pollution, which is, I think, one of the greatest problems right now in many cities. And this is a real health issue, especially for the children and the elderly. But also, green spaces can help tackle problems that are created with the climate change. So hotter summers are creating heat islands in the cities, and the greenery helps to reduce the temperature. And when wet winters come, the green spaces can help retain water. Okay, thank you.
Okay, so like Agata said, there are various groups in the cities that have various needs regarding the use of green spaces. So I would like to say a few words now about why it's important to take into consideration all of these groups and enable them the use of green spaces, and why it's important for their well-being. Because we have known since at least the early 1990s that contact with nature, even if it's just reviewing videos, is helpful for our mental health and coping with stress. And since then, we have learned quite a lot about the relationship of green spaces, urban green spaces, and well-being. And this incorporates both mental and physical health. And for example, we know that people who live in neighborhoods that are greener are less affected by a variety of negative life events. Natural environments are related to increased well-being and less negative emotional experiences and lowered stress. And more neighborhood greenness is also related to lower morbidity of a variety of diseases, especially anxiety and depression. And this is data coming from medical records that were matched with geographical location of patients. We also know that green spaces are inversely correlated with the rate of antidepressant prescriptions. So we know that people who live in greener neighborhoods are less likely to need antidepressants. And for people who already experience depressive symptoms, walking in green spaces can help enhance their mood and memory, which are two of the important areas of functioning for people with symptoms of depression. There are also specific benefits for specific age groups, like for example for people of 65 years and older, so elderly people. And this includes benefits both for mental and physical health. For example, there are really large reductions of diagnosis of Alzheimer's disease and of depression, and these reductions are up to 28%, so these are really huge numbers for the people who are living in greener environments compared to neighborhoods which don't have so much greenery. And these mental health benefits are even more visible for low-income neighborhoods. Children also benefit a lot from green spaces. Green spaces around schools help to improve children's cognitive functioning, things like memory or attention. There are also some studies which suggest that the exposure to greenery in childhood might be related to mental health in adulthood. So it seems that the exposure to greenery can have really long-lasting consequences that span for many years forward. And even in rural areas, the impact of some stressful events was lower for children who live closer to nature compared to children who don't have direct access to nature. And since one of the topics here of this conference is related to crisis, we cannot forget about the ongoing mental health crisis that we have been experiencing for at least a year and a half now due to the COVID pandemic, because the lockdowns and the various restrictions that were imposed really severely affected the mental health of many people. And this includes increases in the levels of stress, anxiety, depression, and loneliness, up to the point that clinicians are discussing a new diagnostic category that would be called the post-pandemic stress disorder, because so many people have been so severely affected by pandemic. But we also know that contact with nature has been very helpful in alleviating the symptoms that come up as a result of the pandemic and restrictions and lockdowns. So researchers have noted increased use of a variety of green spaces, including private gardens, summer houses, or even urban trails that have more greenery are more frequently chosen by both pedestrians and cyclists. And also the frequency of nature use, but also the views from the windows. So more nature, if you can see more nature from your window when you are, for example, under quarantine and cannot go out and see nature outside. So even this leads to higher self-esteem, higher happiness, and higher life satisfaction, and is related to decreased anxiety, depression, and loneliness. So even such small things as views from the window can really have an impact on people, especially in crisis times like the ones that we're experiencing. And also researchers have noted that the motivations for using green spaces outside have changed compared to pre-pandemic time. So now people report that they are using green spaces usually mostly for physical activity, for safely socializing and meeting other people, and because it's good for their health. And we know also from other studies that exercising outdoors compared to indoors has also many benefits, including more positive emotional states, better reduction of stress, and also a higher motivation to repeat these activities outdoors when we compare to exercising indoors. So this shows that the green spaces that are accessible for people are really important, and also make them care for themselves more than if these spaces are not accessible. So this pandemic crisis especially showed or underlined the need for accessible green and blue spaces in urban areas that can help people socialize and relax in a safe way. But also the development and maintenance of urban green spaces has to take into consideration the various needs of various groups that live in the cities in order to be fully effective, so that urban nature can actually be considered a solution for improved public health. Thank you.
Thank you so much. Listening to you, I was wondering how much green we have outside this season, and it seems it's more of a brown and gray type of spaces that we can give to the people at the moment, but hopefully with the spring coming, we'll get this boost of greenery that makes us happier, as Eva and Agata was saying. So obviously, what we are trying to point here is that the right to the healthy city very much involves the right to access to green spaces, and also to make those spaces smarter in ways that Mikołaj and Magda will talk about as we are now engaged in a participatory project which aim at producing healthier spaces. So Magda and Mikołaj, please.
Hi, My name is Mikołaj Biesaga, and together with Magdalena Kołodziejczyk, we are going to present two European-funded projects that we are involved in, EU Polis and HEART. They are both funded by European Commission under Horizon 2020 program. Oh, yeah. And today our presentation will be divided into 4 parts. First 2 I will cover, and then Magda will take over from me. So first I will just do a very short literature review regarding the health and urban green spaces, and later I will tell you about EU Polis methodology, how to implement, how to introduce green spaces into urban into cities. And then Magda will tell you about HEART project and make some final conclusions about both projects. We are not going to present any results yet because both of the projects are in these phases which we do not have data collected yet, but we'll just make conclusions about the methodology and theoretical part. So starting with a very short review of literature, I would say if there is one point from this presentation I would like you to take away, it's this paper, because basically what they are saying, oh yeah, I got your attention, cool. So basically what they are saying that if you have like 30 minutes walk in green spaces, you reduce the risk of depression and high blood pressure, which is pretty cool in terms of individual health, but also public health, because it reduces also the costs of treatment of this to diseases. So remember that if you want to get healthy, stay healthy, just treat yourself with at least 30 minutes walk during the day or regular basis, weekly basis. But should it be just a walk? No, it should be walk in health, in green or blue-green spaces, because apparently research, this one actually, reports that when it's more beneficial for your health, especially cognitive skills or cognitive resources, to have the walk or to spend time in green spaces. So not only 30 minutes, but in green or green-blue spaces, it's important to have during the day or on a weekly basis. So the third paper, the third conclusion I want to share with you is that in terms of health, is that neighborhoods with more green spaces, more greenery. In this neighborhood, people living in this neighborhood are less likely to die from communicable diseases and non-communicable diseases like cardiovascular diseases. So it's better to move to the space where there's more green spaces than living in just in rural area. So then the fourth paper I wanted to show, and this is also kind of important, that all these green spaces, all these green-blue spaces, they not only have a positive effects, but might have also negative effects. So, for example, in terms of fear of crime, if you picture like green space, this devastated green space, obviously it won't affect you positively, but it might involve fear of crime. Especially it is important that this perception or this fear of crime is not uniformly distributed over the population. There are significant differences between genders, and when we think about it, when we are planning for designing green spaces, we need to consider this fact and think not on average citizen or average recipient of the green space, but consider different groups, different gender groups, but also minorities. This is a really great review. I just give you a glimpse of it, and this is the most important conclusion. And the last one is also, I think Eva already mentioned it, that access to good green spaces, like well-maintained green spaces, reduces inequality in mental health, which is also kind of important, that these green spaces shouldn't be just distributed in this nice neighborhoods, but also just, this is a very cost-efficient way of reducing the inequality of mental health. So that is all about the review. So 3 points from this review is that the green spaces not only affect mental health, but also health in general, non-communicable diseases or cardiovascular diseases or respiratory diseases. The second point I wanted to make, that when we are designing the green spaces, we shouldn't be only thinking about the average citizen, but we should consider different groups of stakeholders, different groups of citizens, because like average citizen, there is no one who is average Joe or average citizen. There are different groups who are using the spaces, so we need to consider that. And the third point is that these green spaces shouldn't be just designed in this nice neighborhood, but also everyone should have access, because it is the best cost-efficient way to reduce inequalities in terms of mental health, but also probably in other types of health. How weird that sounds. So now I would like to present to you this project EU Polis, which is basically aiming to bring back nature to neighborhoods. I think this picture quite good describes what we are meant to do. We are kind of trying to color the neighborhoods, the gray neighborhoods in blue and white, introducing better, well-maintained green and blue spaces. And we are trying to understand and see the effects of introducing these changes, introducing the green spaces into the neighborhood on health and well-being. Because the previous studies, they were mostly correlational, and now we are making an intervention and creating something new or renovating something. So what are the three main aims of this project, of this methodology? So basically, it's transforming neighborhoods in greener and more friendly areas. And so, but as I mentioned before, it's not about creating any green space. It should be multidimensional. We should be thinking in terms of mental health. We should be thinking like creating this green space, also considering social aspects, economical aspects, and obviously environmental aspects, because we are trying to fight nowadays this climate emergency. So European Union defines nature-based solutions as a thing, as a solutions inspired by nature and supported by nature. They have, they have these effects on, these multidimensional effects on both social environment, health, well-being, and so on. So taking, for example, creating these small pocket parks, they can reduce floods, they can reduce urban heat island effect, and so on and so on. So they have both environmental effects and also like individual effects or public health effects. So the second point, or the second aim of this project, of this methodology, is to create these solutions not by authorities, but in participatory processes, because as I mentioned, this is really important to consider all groups of stakeholders. In this project especially, we've already mapped different stakeholders that will be involved or they are living in the neighborhood. So we are trying to reach to as many different groups as and identify different groups of citizens to learn about their needs and to understand what they would like the neighborhood to look and how to engage them the best possible way. So we are consulting not only planning, but also implementing the changes. Obviously, we know that we want to make the neighborhood greener, but how we are going to do it, it depends on the needs of specific groups of citizens and stakeholders, because as I said before, we are not thinking about the average citizen, but we are talking about specific groups, either women, minorities, or elders, or children, because they use the space. We've already learned it from Agata that they use the space or they use the city in different ways, so they have different needs. And we try to meet them by consulting and implementing different participatory processes depending on their needs and their availability. So the third aim of this project is to assess the impact of these changes we are implementing. Basically, we are trying to use the longitudinal approach, which means that we are measuring the baseline status on these different aspects, social aspects, environmental aspects, economic aspects, health, well-being. We are measuring it before the intervention, and we are going to measure it afterwards. And hopefully we will see the difference between the baseline status and afterwards status. And hopefully we will see not only effects, but beneficial effects for all of them. And based on the literature I just presented to you, I mean, hopefully it's kind of theoretically proved, so it's more than hopefully. So how we are going to do it? We are going to use different tools and different methods to do that. Obviously, we are going to implement some ICT tools to measure. We are going to use, for example, sensors to on the site. In these places, we are going to build these NBSs, these nature-based solutions. We are going to place their sensors to measure temperature. We are going to measure the heat island effect. We are going to measure the air pollution. We are going to measure different environmental aspects of the climate emergency. But also we are going to measure the local community. We are going to use to get the data from local community. We want to check, for example, social cohesion before and after, because we believe that creating this space, this new space, friendly space for different groups, will also improve community bonds, and it will improve some social aspects of the local community. And how we are going to measure the positive, hopeful effects of health and well-being, we are going either to, not either, we are going to use both some sensors like wristbands, which are going to measure blood pressure, and they are going to also measure the emotions and the happiness of the participants, citizens, based on their physiological reports. And also we are going to use some more traditional tools, either from psychology or sociology, so questionnaires, observation, and interviews with those people who we couldn't really use these ICT tools. And I will now hand to Magda. Thank you.
Mikołaj presented a holistic picture of a great idea, which is connection between urban planning based on nature solution with social needs, and a new dimension of participatory processes, which, as for me, is a great that we have a new way which can have many positive effects. And last but not least, idea of healthier society. HEART project, which is here presented, we have in which we have pleasure to be a partner, is focused on social health. So maybe it will be some quite straight in your interests in interest of what are you doing. The project EUPOLIS, about Mikołaj was talking, and HEART, they are from the same family of project, so connected with urban solution. But the HEART mission is an integrated approach that aims to improve urban health, and reduce urban planning methodology, blue-green solutions, and implementation some techniques which help change individual behaviors of citizens. There are 2 points, 2 main issues which distinguish HEART project from EUPOLIS. The one is that here in this project we haven't got some architectural urbanistic interventions. We use the sites, green sites, which are now in our cities. The second issue, which is different, it's the main goal of HEART. So it's assess the impact of regular visit in areas with nature-based solutions, blue-green solutions on health and well-being of patients with non-communicable diseases. We will concentrate in this project on patients will be selected in medical base on their medical history. There will be 4 clinical groups: neurological, anxiety and stress, metabolic, cardiovascular, and respiratory. Patient will be under scrupulous medical observation by local medical centers. And as Mikołaj mentioned before, they have some new technologies. For example, wristbands, which make which give the medical team information about some life function as blood pressure, heart rate, rhythm, or mood. And this is opportunity to gather this data together and analyze by medical team, but also by our social team. It could be a good point to make our social studies. This is overview of our project. So as you see in green area, we hope that there will be happier people. And conclusions. It's connected with these 2 projects. We would like to have hard evidence data on effect, nature-based solutions on health and well-being of local communities. Hard evidence data of regular visits in areas with NBS, nature-based solutions, on health and well-being of patients with non-communicable cardiovascular diseases. We would like to make a livability model that allows to assess the impact of NBS implementation that captures both health-related and non-related aspects. And at the last, inclusion of often underrepresented voices in creating public policy and designing public spaces. And it's all for our side. Thank you.
we don't have so much space here, so we have to share. Thank you so much. I think this is one of the many ways that we are trying to approach also the impact assessment of different type of urban intervention. I think this is always what has been a challenge in different types of policies that are implemented to enable city health. There is one very important point that Magda will follow with, which is the citizen involvement and how the citizen grassroots capital can really make those policies better, and what we need to do to highlight it.
Good afternoon. My name is Magda Roszczyńska-Kurasińska. Actually, I was so inspired by previous presentations that I came to conclusion that the title of my presentation should be a little bit changed from citizen-driven to community-driven healthier cities. The new topic would acknowledge the fact that any adoption of social innovation happens within a community. The interaction and preferably smooth collaboration of different groups of actors is a necessity. Citizens are just one of these groups, and although very powerful, they need to cooperate with others, which might facilitate or hinder their efforts. When we look at different communities, we see that some face the challenges quite better than others. And in our research, we want to understand what makes some communities better than others in overcoming obstacles and adjusting to always changing environment. In one of our projects, CLICK project, we studied the effectiveness of communities in implementation of environmental friendly solutions. And we came to at the conclusion that social sustainability concept developed by Missimer and his colleagues can be a powerful framework for diagnosis of communities. And I want to tell something more about this social sustainability framework here. According to Missimer, Robert and Broman, there are 5 factors that facilitate social sustainability, understood as capability of the community to overcome challenges and unexpected crises. It is trust, common meaning, diversity, capacity to learn, and capacity for self-organization. Yesterday, we heard that all of these factors played important role in success of programs dedicated to harm reduction. First of all, I would like to underline the role of common meaning. That is, common meaning is a shared understanding of people, what is happening in the world, and more important, in their neighborhood. As the diversification of cities is growing, the common meaning of what is happening, what are the goals of the community, and what are the priorities might diverge. In situation of crisis, the understanding of the challenges that different people face align, and priorities are set the same, are alike. People for a short period of time have the same goals, therefore it is easier for them to collaborate and self-organize. And we actually heard yesterday that almost in all presentations that COVID pandemic speed up the process of overcoming the homelessness in the cities, which might be the effect of the alignment of these goals between different groups of people. But common meaning is not all that we need. We need also different skills, which is hidden behind diversity dimension, which actually in the case of big cities is seldom a challenge. The challenge is what my previous to me presenters said, the embracement of the diversity of actors in participatory processes. The next important characteristic of the sustainable community is capacity for learning. People need to have the capacity to learn and to be able to adjust new information, to unfreeze the current understanding and become open to new information and data. We heard yesterday Jacek Harmast saying how the understanding of drug addiction as rather the choice than illness in the Polish culture lingers, making implementation of some solutions quite difficult. At least there is trust between different groups of people, but also NGOs, scientists, public institutions, and city administration. Trust not only in, when we are speaking about trust, it's not about trust in good intentions of others, but also in the capability of making a change. So the trust is very important, essential element of social sustainability. Especially nowadays, when the misinformation surrounds us, we need to restore trust towards not only other people, but scientists, experts, and authorities. And in one of our projects, ICIT projects, which the shortcut stands for Citizen Science and European Democracies, we try to understand how through citizen science we can restore the trust, learn people critical thinking, and build engagement. You probably heard of citizen science in context of counting birds, monitoring migration of turtles, but it appears that these programs can be used also to study health-related issues. And the aim of citizen science programs is to engage general public in monitoring of some aspects of reality, collection of data, which are further analyzed by scientists or by citizens themselves. There are diverse approaches to involvement of citizens. And although not many studies has been conducted yet, there are some first triads, like study on effects of weather on pain, monitoring of effects of air pollution, noise pollution on different aspects of stress and well-being. And also one very interesting study showing how involvement of adolescents in design of the study and then conducting the study can improve to find new factors of attention. The takeaway of these studies is that place-based citizen science improves community building and capacity for self-organization. However, the long-term effects depends on the design of the study. When the diversity of citizens is not reflected in the study, or the responders are used just for data as data providers, the effects might be dissatisfying. These solutions then can build distrust among citizens, and citizens can question whether the benefits for all partners of the programs are equal. And it happened in several programs, citizen science programs, thus trust didn't increase at all. It decreased. So conducting these programs needs careful design. But not to be pessimistic, I wanted to finish with positive effects of citizen science programs, which show that they increase self-efficacy, strengthen connection between people, place, and nature. And citizen science can help people to improve the ability to understand data and to interpret scientific information. Thank you for your attention.
Thank you, Magda. And with this, we are finishing the data-focused part of our meeting. And I wanted to invite our last speaker, Professor Marek Rymsza, who will present a new initiative that we set up. We are proud to be a partner with this initiative at the University of Warsaw. And hopefully, this will also bring quite a lot of good connection between practice and academia.
Thank you very much for being invited here. Yes, our initiative is very fresh. We just make a formal agreement last week. But of course, we are enough prepared to start realizing this initiative in the beginning of coming year. In March this year, we organized an international conference when we start cooperation on the idea which is called policy of the institutionalization of social services. It's a new idea of European Union agenda that social services, generally speaking, has to be provided and delivered as close to people as possible. And we decided to organize a special task force group of university researchers to monitor such a policy. This group is based on partnership of 3 university entities. It is Faculty of Applied Social Sciences and Resocialization. I'm a Vice Dean of this faculty. Robert Zając Institute for Social Studies and European Center. Why we meet together? Probably because in all these 3 entities, the idea of doing applied social sciences looks vital. We built this partnership to have a chance to monitor what's going on 3 levels. The European Center is this entity who will be active in analysis on what's going on the EU level and to compare policies implemented in different membership countries, East, West, North, South of Europe. We, as our faculty, we would like to focus on implementation of this idea on the national level. So to monitor the governmental policies in this field. And Robert Zając Institute would like just to monitor what's going on in our city. So just to be enough clever to catch what's going on just outside the windows of our buildings. And of course, to have any success in this, you have to implement this on all these 3 levels. It doesn't make sense to do something on the EU level when the country is going other directions, and the same with the state policy. It has to be done, in fact, on the very local level. Our government decided to build a strategy of what is called strategy of social service development. This is the name of this official programming document prepared under this, let me say, EU agenda. And to focus this process of deinstitutionalization on 5 fields. These are mental health services, foster care, support for homeless people, support for people with disabilities, and elderly-oriented services. We, as a research group, decided to add 2 other fields. It means addictions therapies and services offered to refugees and migrant people. What does it mean, this idea of deinstitutionalization, when you try to operationalize it? It is a tendency to replace, whenever possible, a kind of institutional care organized as a long-term care, 24 hours a day, in a special places located, let me say, outside the common life of the people. And the idea is to replace such infrastructure by social services, which are, let me say, environmental oriented. So it means that they are community-based, familiar, and personalized. And where is the main problem in implementation? Because let me say that on the, let me say, the level of idea, there is a rather consensus that it's a, let me say, good direction of, let me say, reshaping public policies. The problem is that, of course, there are some, let me say, defense mechanisms of those who are currently involved in doing services in a way as it looks now. So the idea is not to lose workplaces, for instance. On the other hand, we have some, let me say, radicals who just want to promote under this idea closing institutions. The best next year, or maybe not next year, in 5 years. But everyone has to be closed. And on all this, of course, there is a tendency to polarization. Much, let me say, stronger impact of radicals, stronger defense mechanism of all others. So what we would like to do, first of all, to monitor what's going on. So just to analyze in a very objective way what's going on EU level, on national level, and on the local level. But secondly, we would like to focus on, let me say, promote positive solutions. To overcome this kind of a quarrel between both sides. I already mentioned them. What may be done? First of all, we would like to promote the idea that institutions has not to be closed, but rather to be open. Our meaning of opening, of course, is not to build new such institutions. The idea of opening is just as it's coming of the idea, what does it mean to close the door? There's nothing wrong that we organize services in special buildings, for instance. If you need kind of a special infrastructure, you have to locate them somewhere. They cannot stay on the streets. The problem is of closing doors. That you put some people outside the common life, close the doors, and organize their daily activity in a different way. That's the crucial element which has to be changed. And of course, if you close the doors, you open a kind of a game whose interest has to be pushed at on the front line. So, for instance, helpers or the pensioners or something like that. There is a tendency to organize special rules, to bureaucratize them, and all these things. We would like to push the idea of open the door, please. So just to give an access to these places, to this infrastructure, for all citizens who would like to come and use some services. And also not to close the doors for those who are stayed there. They may go out and do whatever they want as just citizens, because everyone is citizen. That's the idea. Secondly, we would like to promote the idea of cross-sectoral cooperation. So to give as much space as possible in social service delivering to NGOs, to social enterprises, to charity church-related entities. The diversity of those entities is just a way to make them more environmental oriented. The third idea is to reshape the relation between those who are, let me say, professional helpers, the specialists, and those who receive the support. So build this relation, not a kind of a control, let me say, idea, but rather a kind of a partnership. And the fourth is just to promote the idea of the agency of people who are supported. That if you receive any kind of support, any kind of services, it means that your well-being has to rise up, but you do not lose the control on your life. And we believe that if we will be enough clever to promote all this idea, to equip the specialists with this, let me say, kind of knowledge, competence, the institutionalization will be just implemented. Not by, let me say, radical solutions, but by daily practices. What are our, let me say, missions and activities we would like to undertake from the beginning of the coming year? First of all, to present some kind of annual reports. So what's going on in all these 7 fields of services. Secondly, to provide our own research and analysis. And we would like also to develop a kind of a, let me say, theory, which we call it now as a theory of solidarity capital. Now there is a fashionable to develop the theory of capital. It's coming from economy to all social sciences, also to sociology. And the idea is that the capital is any kind of a resource you can use to produce public benefit. And we would like to show that you may distinguish a special kind of a capital. We call this as a solidarity capital, which is a kind of something which summarizes what is called as social capital and institutional capital. Because in this idea of the institutionalization, social is put as in opposition to institutionalize, something which is institutionalized. From sociological point of view, I am sociologist by training. Thinking to organize the society without institution is utopia, because everything which is organized is some kind of an institution. So services, 100% environmental oriented, are also institutions. So the idea is how to build institutions in a way which are not the enemy to what we call the social, but which is a kind of, which is how to say, complementary to it. That's the idea, and we would like to develop it. Thank you very much.
Thank you. So this is, we're closing our session with a place for discussion. If there is any idea or inspiration that you would like to share also for us for the next year of different planning for studies, and do you have any questions that seems to be very relevant to what Professor Rymsza was talking about, please share it with us. Obviously, I think the presenters are willing to answer any questions if anything was unclear. We are also super open to comments on what was presented.
I want to say that Anya and Magda are members of this team.
Yes, and really happy to be one. So, are there any questions? Okay, there's a question to Eva. Do you have a mic? Should you grab one? You said green space near schools can improve cognitive function in children. Has this been disaggregated from other socioeconomic factors, for example, social, urban, suburban, rural life?
There is not that much research on this, but usually the studies that show the improved cognitive function also try to rule out any other variables that might be of interest. So things like socioeconomic status or other areas that can be related to cognitive functioning are usually taken into consideration as well, so yes.
Thank you. Another question is the amount of green space in Warsaw increasing or decreasing? So we've been actually pretty proud to be a very green city of Europe, and there's the city office is putting a lot of emphasis of introducing these green policies. Obviously, this doesn't mean that we are living in a paradise, and there is a huge problem with air pollution that we've been fighting for the last couple of years. But in general, it seems that the green spaces, for me as a resident, I think for others from the group, they would agree, they are increasing in amount and also in quality. So we see the positive trends in that respect, which hopefully will bring some of the positive effects that we were talking about before. There is a third question. Is there ever a tension between the need for urban green space for communities and the need for new social housing and accommodation? Shall I answer that? Obviously, there is a great tension, and there is not enough money to bring both, but I haven't been aware of any type of conflict around this, because at the moment, if there is a new housing policy or there's a new housing initiative being implemented, it usually is already packed in a green area. So there also we have some positive examples of communal housing that already use blue-green solutions that we've been talking about. And as Warsaw is actually not our pilot city in neither FPOLIS or HART project, we will also hopefully see this type of implementation in other Polish cities, and we want to promote this type of thinking. So especially in the public investments around housing and creating shelters, for example, this is exactly the area where this type of innovation can be included. And I think there's a question to Mikołaj. Are the positive effects of spending 30 minutes per week in green spaces increased when people meet up together in groups of 2 or more? And having beers?
Okay, to be honest, I'm not sure, but I would expect that yes, like spending time together, and it increases for sure well-being, so being social, and probably in green spaces it additionally increases the effect. So I would guess yes, but I don't have any data to prove it right now. I would have to do like more research, like desk research, to be sure. But my intuition is yes, it is.
I think it's a great research question, actually. Eva, you have a comment? I will add it to our list of questions, by the way.
Yes, there are many aspects of being in nature that are being researched, and there are many mechanisms that are proposed, and socializing is one of them for sure, but it seems that it's not like the main aspect that helps people achieve better well-being. It seems that the sole experience of being in nature is the strongest effect, but there are also others, and this includes socializing and increased physical activity, also things like increased exposure to some other than normal in the city microbiome, for example, which is also beneficial for well-being and so on. So socializing itself is one of the factors, but not the main one.
I think as long as you're walking in this green space with other willing participants, and not, for example, with super tired minors, like my daughter last weekend, that Agata was also participating in this supposedly really nice walk in the green space, but she was so unenthusiastic that she actually spoiled the pleasure for us. So I think it's a tricky question. It's a really good one, and I think it's worth pursuing. And I had one question for Marek. You talked about difficulty mapping responses across different EU countries, but do you hope this project's work can be transferred to other places? Yes.
The idea is to observe what's going on, of course, on the EU level to understand the agenda, but then to compare Poland with other countries, and also to promote our good solutions to be available to others. Let me say that each country is, let me say, there is no country which will be mature in all these fields of services. So some are better, let me say, in elderly policy, some other with the foster care. For instance, foster care is deinstitutionalized in Poland nowadays. We are only just at the very beginning point of implementing this idea in the field of service to homeless people, this idea of housing first. We just have 20 such entities all over the country, so almost zero. So that is why we have to look one to another, and just to share our experiences. That's the idea.
Yes, and we're very much looking forward to looking for good practices. So also the yesterday and this morning was a good experience for us to gather those ideas. And I know that the City of Warsaw representatives were there listening to us, and hopefully this will be a good inspiration for the work to follow. Shall we wrap up, or are there any questions, Kasia? Yeah.
Hi, I have a question. My name is Piotr Toczyski. I was listening with curiosity and interest. I was reading during the break in the lobby the strategy of the City of Warsaw regarding some social factors.
Solving the social problems, yes.
And you actually discussed some health-related issues as being also social. How do you call them? Social.
Yeah.
Okay. And my question would be: is it the case that some factors related to health actually disappeared from the list of indicators? Because I remember seeing the list that was a bit longer. That's my first question. Another question is, what about mental health? Currently, within the project we discussed unofficially during the break, which is funded by European Commission and so on, health-related project, we focus on social and environmental, social environmental aspects of mental health. And can, let's say, neighbors, can workplaces, can localities take care about mental health, basically the depression, which is the top mental health problem. And this is the question, if we could actually make a move, or how could we make it, or how do you assess the opportunity to make it in a city such as Warsaw, which is the leader of the region in Central, Eastern Europe, Central Asia and so on, which is the city which is the leader. How do you assess the possibility of including factors, actually indicators related to mental health and to stigmatizing mental health? Like, for example, what's the level of destigmatization towards mental health related issues, or how many people in the neighborhood agree with the statement that depression is the real disease, let's say, or that it can be treated, or that it can affect anyone? Wouldn't it be good to also supplement the existing list with this, especially regarding to your presentations, in which you mentioned that green areas are helpful in prevention of depression and so on. So that would be this this borderland of very soft and very hard things about which we discuss. And, my question is actually a statement as well at the same time.
Yes, I know you're working in the field,
rhetoric.
so you have agenda there.
I'm paid to ask questions like this, but it's in good faith. And I'm actually really interested in what's happening to this list of factors. Why is it smaller, not longer, and why is not mental health included in it? That's all.
That's obviously the question that a representative of the City of Warsaw should answer, but I can tell you how it looks from the process side. The health is one of the sectors that is now being taken care of by a specific policy that will be developed in the next couple of months. So obviously, when we are creating this strategy for solving social problems, health is one of the very important issues and topics within this process. But there will be a very specific targeted policy that touches on the health. That's why some of the indicators were not central for this solving social problems strategy, which is just one of the many documents that will be now developed under the big umbrella of the social of Warsaw Development Strategy. And this is what we are aiming at till 2030. And I think during our discussion, mental health was actually one of the very important, and I wouldn't say maybe one of the main problems that we discussed, because we can see a very important change in type of beneficiaries of the social aid and social services in Warsaw. So we can see this shift from people who are marginalized and have a lot of economic problems, or who you would call problematic families, who try to fight not only the problem of poverty, but also alcoholism or drug abuse. No, we now see quite a lot of people in need of help who are coming from more affluent neighborhoods and backgrounds, people who have problems dealing with stress on the everyday basis because, for example, of the mortgages crisis, because of the high expectation that this type of city is putting them under. And we've been trying to deal with it also in a way that helps, one of the goals of this strategy is to help destigmatize social services. So people from the middle class, for example, people who feel that it's not for them to go to the social service, would feel that it's actually exactly also for them, and they can feel free to use it as residents of this city, and not to mention taxpayers. This is something that is developed for them and should be treated as a right, again, one of their rights to access this type of services. Not only in the mental sphere, but mental health seems to be one of the very important new issues that this strategy is dealing with.
So it disappeared only temporarily from the umbrella, but it will be under the umbrella, if I grasp it correctly. Yes?
Yeah, exactly.
Thank you. Thanks.
There's another question?
Yes, I'd like to ask the presenters whether they are optimistic about the future of the city.
This city or all the cities?
All cities. Future of urban living in cities, because we see sort of swings and roundabouts. You know, cities become popular, then you have, you know, the spread to the suburbs and to the country, and then cities become popular again, and we've seen in the last 20, 30 years the regentrification of the inner urban areas. And in the context of COVID, there is a sort of thought that the richer people will flee the city, so you have that new donut effect with the poor people left in the middle and the rich people go off to the country or work as digital nomads somewhere else and abandon the city. So you potentially have a greater concentration of poverty and misery left behind and less money to support everything that's needed within the city. So kind of ending on a note about whether there's an upbeat view of this or whether it's maybe a negative future for cities.
So I will ask all the participants to answer this question, because I am very much an optimist in that case. I think we are going in this, we have this new stage of cities development that can be visible around the globe. Maybe, and I hope that Warsaw will be one of the cases of really looking forward. And I think the climate crisis created a very important impulse to do that. And now the COVID crisis is another. This is something that you cannot ignore. You really have to make an effort. And one of the spaces in which this effort is being made is to allow more voices from the grassroots and more effort from the grassroots. So really energizing and also allowing communities to take care of some of their problems, because as you said, the cities are not able to deal with all of it. It's just not feasible in economic terms. But it seems that there's more and more knowledge and also willingness to act on the neighborhood level. And I see a lot of hope in that. I've been studying urban movements for several years now, and I see it as one of the most vibrant sides of civil society in Poland, for example. So this right to the city movement, it has been also opening many doors and many opportunities that seem to not be there before. So if this type of thinking proves contagious, I think we are going to be in a better place than the future that you talked about. But we have to take into account that this is the main threat that we face. So thank you for mentioning it. I think obviously being too optimistic would be too risky also. But I'll stay as I am. Would you like to comment? Are you optimist or pessimist?
I would say I am optimistic about the cities. I mean, mostly because I am involved in two projects which are making me optimistic. We are talking about making the cities more greener, and also we are talking about changing the cities and matching the needs of the citizens and different groups of people, not just average either authorities of the cities or just average not existing citizen. So I'm kind of optimistic, and also like looking at my neighborhood, it is changing and I like the changes. Maybe they are not coming too fast. I mean, they are not that rapid as I would expect them to happen. But for example, taking Warsaw as an example, I like the COVID pandemic made me cycle more because I refused to use public transport, so because of obviously COVID. So I discovered that Warsaw is kind of well connected in terms, I mean the destinations I am going, they're well connected in terms of bike lanes. So I can see the change because I've been doing the same route for years, and now I can do it by bike, which is for me a positive change. Also in my neighborhood, the parking spots are changing. They're all taking less space from the pavement, so it's easier for people to walk. So I can see positive changes, but obviously it's just my perspective and the projects I'm involved in. But yeah, I am kind of optimistic about the cities. I mean, fingers crossed. Thanks.
And there's one point that I think is important here, is that when we are working on those solutions and processes that are very much part of the F-Polis and HART philosophy, one of our main goals is to involve citizens that are not from the middle class and higher. So those who are there to stay, because they may have less choice, but they should be therefore even more important part of this process. And it's a huge challenge. It's been a really interesting adventure up to now, very frustrating to talk with engineers who has a very specific way of doing things, but also to talk with city administrations that in many cases is pretty, afraid of having a lot of participation, and they're also worried that people don't really come to the meetings, they don't talk about it. So we are still facing this challenge, and I hope that even with small steps we will be able to introduce and promote this new method of really pressing for more responsibilities from engineers' side, for example, that it's not only about entering the space and changing it so it has all the technical and cool aspects at the end, so you can be proud of it. The same with architects and urban planners. This is really a very interesting new venture to make them responsible for the social effects that place brings. And I think monitoring health aspects is one of the very simple ways of pressing for different type of planning and also for policy making in the city. That's why this was so interesting to be part of this conference for us. Is there any other question? I think it's time to wrap up, and Kasia, will you join me here to say au revoir?
So, thank you. So, the 11th edition of City Health Conference has come to an end. And let me just start with a big thank you to everyone who was involved in making this event happen. So thank you, Anya, thank you for all the team, thank you for the City of Warsaw, thank you to all the presenters, the participants both online and live. And over the last 2 days, we had opportunities to hear about great work that's taking place, is being done in many different locations and places. And this great work can be developed and delivered even in the most trying of circumstances. And in some cases, it was the pandemic that worked as an accelerator of innovations and changes. So changes that should have been done years ago, changes that couldn't be done years ago, and changes that are happening right now. And let me just quote Magdalena Dąbrowska from earlier on, without the sky falling in. So I would like to take a moment to offer thanks to all of you for your dedication, compassion, and empathy. So just by coming to this event, you are already a valued part of our work. We as GPHN are a young organization, although we grow out of City Health conferences. But this is what GPHN is about bringing different people together and about facilitating the collaborations and about helping people and organizations to break out the silos and make the links and connections. So I encourage you all to visit our website just to look through our projects, and I hope that we will be able to collaborate together. And 3 final information. So each year we are organizing City Health Conference in a different location. So the principles remain the same, but the flavor is local. And I'm so happy and proud to announce that next year's City Health Conference will happen in May in Nur-Sultan in Kazakhstan. And I'm really looking forward, and I'm gonna keep you updated about the development of this event. So that was the first one. The second one, more practical, please complete the feedback form and questionnaire that we will provide you with, either online or in a paper form, because it helps us. It helps us to craft those events. And the third thing is, although it is the official ending, I would like to invite you all for the satellite workshop on media training, especially for NGOs, but I think we can use, we can all use the knowledge. So thank you very much. And see you in Kazakhstan.